Good evening, one and all. It is indeed my great privilege to welcome Dr. Ramesh Agarwalla, the President of HSI, to this webinar on endoscopic approach to the small midline ventral hernia. At this outset, I would like to extend my hearty thanks to our President for giving me this opportunity. It was, in fact, a great pleasure organizing this event under his guidance. Once again, I welcome you, sir. And I take this occasion to welcome our foreign faculties, Dr. Jose Macrio Pilona from Philippines and Flavio Melchor and from USA, who was there with us in Hernia HSI Con Chennai 2018. With a great honor, I welcome both of you. I also welcome my seniors, colleagues for this event, hoping for the wonderful, worthful 2 hours of knowledge sharing for everyone. To put it in nutshell, our previous academic in HSI were on open hernia masterclass 1 and 2. In that, we covered in open hernia, we covered onlay repair, ventral hernia, applied anatomy, open supply repair. In laparoscopic hernia, ventral hernia, classification of hernia, anatomy of anterior abdominal wall hernia, processes and fixation, IPOM plus, where we are images in hernia. So we had so many things in ventral hernia. Part 2, we had a anterior component separation, posterior component separation, parastromal and atypical location hernia, endoscopic retromuscular repair for ventral hernia and scola. Still, it's not over. The part 2, 3 is come now, like with your ventral hernia, for small hernia, what we are going to do. It's a question mark with your juniors and our who is starting with their hernia surgery. So we plan to enlighten you all in different perspective in ventral hernia. Good luck, one and all. Over to you, Ramesh Agarwalla, sir.
Thank you very much, Shiva. Am I audible to all?
Everyone, sir.
Yes. Thank you very much. First of all, I would like to play us on record. This entire program is the brainchild of Shiva only. And it is totally his brainchild. He's conceived and conceptualized the entire program. And I really congratulate him for putting in the topics and bringing in such esteemed faculty for this program. I, on behalf of HSI, would like to invite all the faculty, namely Dr. Jose, Dr. Fabio, Shiva, Dr. Rahul, Dr. Avinash, Dr. M. Ramesh, Dr. Albert, Dr. Anil Sharma. And I would also welcome all the delegates who are participating in the program. And I would like to thank the Docplexus team headed by Kritika for always supporting us in these programs. As you know, Hernia Society of India is a part of Asia Pacific Hernia Society. Our main aim is to promote the art and science of hernia surgery. We have been having these master classes and webinars for the last 2 months on a weekly basis with a very good response. The last class, as Shiva told you, we had open ventral hernia, where we had 2,800 people who had logged on to this program. As I said, our main aim was to propagate the art and science of hernia. Now, hernia itself has become a big science, the science of herniology. We have very distinguished faculty, and the topic is very apt. This is endo-laparoscopic approaches to small primary midline ventral hernias. These are the hernias which come to us in day-to-day practice and come to the common surgeons. The larger hernias are for the masters, but for a day-to-day common practice, these are the hernias which we deal with. So with these few words, I will give over to Shiva to carry on the proceedings. Over to you, Shiva.
Thank you very much, sir. Without wasting the time, I think so, we'll go to the first topic, the IPOM plus, when and when not. This is going to talk by Dr. Jose Macrio Pilona from Philippines. I invite Dr. Naveen Alexander to introduce Dr. Pilona.
Good evening, everyone. This is Dr. Naveen. I'm from Chennai. Hope you're all having a very safe lockdown.
Sorry. Naveen, I should introduce Naveen first. Dr. Alexander is a professor of general surgery and assistant dean of the student and faculty of Johnson & Johnson Ethicon Institute of Surgical Education. This Ramachandra Institute of Higher Education and Research Center is a man of like enthusiasm. Please, sir, carry on.
Thank you, sir. It gives me great pleasure to introduce Dr. Jose Macario Felona for this evening here. Sir has been a big force in the Philippine surgical field. He's even in the past, he has been the past president of the Philippine Hernia Society and also a past president of the Asian Pacific Hernia Society, with a long list of publications to his name on his CV, many of which are related to herniology. I take great pleasure in welcoming Sir Dr. Jose Macario Felona to give us his talk right now.
Thank you so much for the Hernia Society of India, Professor Siva, for inviting me, Professor Rahul, Professor Ramesh, Anil. Good evening. I'll share my screen now. Okay. Can you see it?
Yes, sir, you're very much visible, sir. You can carry on.
Thank you. So the topic that was assigned to me was IPOM and IPOM Plus, when and when not. So this is my disclosure slide. I do give some talks for Medtronic and Vibron locally here in the Philippines, and some lectures for some pharmaceutical drugs as well here in the Philippines. This is my university, and this is our hospital. It's a 1,500-bed hospital. But currently, our hernia operations are put in hold because we are a COVID center, and we do have a big chunk of our hospital now dedicated to the COVID pandemic. So some basics, the incidence of ventral hernias, we all know that 10% of all laparotomies will generate incisional hernias. And of course, the bigger the incision, the higher the risk of having a hernia. 77% of this are midline hernias, some are lateral, and some are iliac hernias. There are risk factors for the development of incisional hernias, and they can be divided into patients' factors and surgeon's factors. So for the patient, if you're dealing with an elderly patient, obese patient, patients on immunomodulating drugs, diabetics, and smokers, then they are at risk for the development of incisional hernia. For the surgeon's factors, the suturing technique of the surgeon matters, the material that he decides to use, as well as the location of the incision. So this is just a slide to show to you that definitely mesh repair has an advantage in terms of the management of incisional hernias. And in this consensus publication from the IHC, it just basically tells us that there are several places where we can put in the mesh, and the most popular probably in the placement of the mesh is either the sublay or the underlay or the IPOM. For the hernia guidelines in 2019 published by the IEHS, it also mentions that mesh has the advantage in terms of recurrences. The sublay mesh has fewer recurrences compared to the other locations of the mesh. However, mesh repairs are associated, of course, with surgical site infections and seromas. And one thing new is that if there's divarication of the recti, then this has to be repaired because there's an increased recurrence rate when you are dealing with the repairs of small midline hernias. This is an algorithm presented by Yuri way back in 2017 in the SAGES meeting. I just wanted to you to concentrate in these three triangles. And based on my talk, basically, the laparoscopic ventral hernia repair are mainly reserved for small to medium-sized hernias. Or if you have a previous onlay, then chances are you can probably tackle the recurrent hernia as well laparoscopically. So to summarize that algorithm, the laparoscopic approach, the IPOM, is reserved for small to medium-sized hernias. It's not recommended if you have big hernias with loss of domain, if there is the presence of high-grade obstruction, because the visibility in laparoscopy might be a problem, and if you have a perforation, going to prove certainly that is not allowed if there's a contaminated field inside. Just to mention, the retrorectus space, that's actually the new playground now for the hernia surgeons, and the advantage of it is, of course, there's a sublay placement of the mesh. The space, this retrorectus space, can be extended further to the tar space if you need a wider mesh. And it has also the advantage of using a non-coated mesh, which makes it less expensive. Now, since this is a confined space, some surgeons actually opt not to put any fixation, which plays a role as well in terms of abdominal pain after surgery. And playing around in this space, it actually brought about innovative techniques from open to MIS to robotics. And we now have this alphabet soup of different types of repair using the retrorectus space. So why IPOM? A bit of history. The technique was first reported by Carl LeBlanc in 1992, but he did not term it IPOM. He was actually thinking of the term IPOM, or intraperitoneal onlay patch. So he reported it in this publication for 5 cases, medium-sized hernias, 1.5 to 6 centimeters squared, using EPTFE as the prosthetic device. Furthermore, down the line, the term IPOM actually was first used by Bob Fitzgibbons as a technique of laparoscopic groin hernia repair. So this was brought about in this meeting. This is a investigators meeting looking at laparoscopic groin hernia repair, and this is also where the term TAPP and TEP was coined in this meeting. So what about IPOM as the term for ventral hernia? This was first used by a German, Dieter Berger, in 2002, but he actually coined the term IPOM based on watching a video done by Carl LeBlanc as well. Todd, of course, reported his own series early on in laparoscopic hernia repair for incisional hernias, and he termed it LVHR for laparoscopic ventral hernia repair. Indications for IPOM, as I mentioned, small to medium-sized hernias. The good thing with IPOM, it's not so difficult to learn. It's a very simple approach for ventral incisional hernias. Of course, it follows the Laplace law and has a good result in terms of recurrence and complications. Problem with IPOM is this: it has its own contraindications, such as if the patient had multiple previous abdominal surgery, if you're dealing with a strangulated bowel, a large hernia, if you have a very wide diastasis recti, if the patient will require some form of abdominoplasty, if there is loss of the main, and if there's an enterocutaneous fistula. Let me show you a short video. This is an old video of a patient. This is a 58-year-old male post appendectomy through a Rocky Davis incision, and he developed a hernia in the Rocky Davis site. You can only do thermal devices or hot scissors if you're sure that there's no bowel involved. What is, of course, advisable is that you have to use cold scissors in the adhesiolysis that you're going to do. So once you're done with the adhesiolysis, you measure the defect, and then after measuring the defect, then you put your ventral patch. So IPOM is actually sort of a bridging patch just to close the defect. So cold scissors, this is the surgeon looking at possible bowel injury. And then this is an old video, as I mentioned. You still have this PTFE underneath and a Prolene mesh above. So the mesh was, of course, fixed with a double crown technique. So problems with the IPOM, the outcomes are, of course, affected by the size of the defect. There might be adverse outcomes due to the placement of an intraperitoneal mesh, and this is actually the argument of the surgeons who wants to put the mesh in the sublay space. And the adverse outcomes are adhesions. The mesh can erode into the bowel, to the bladder, or whatever it's adjacent to, and it is associated with chronic pain at about 10% in most reports, and this is mostly due to the transfixing suture that you put. It's also associated, of course, with a higher cost due to the coated mesh that you're going to use, a higher seroma formation. Of course, the bigger the hernia, you might have a chance of eventration, and this will brought about cosmetic dissatisfaction to the patient, and there's a higher recurrence if the defect is not closed. And that brought about the IPOM Plus technique. So the IPOM Plus was first reported by Chilala in 2016. He reported in 1,326 patients. The closure was done either laparoscopically or extracorporeally. And you would note that the complication rate, the seroma rate, the chronic pain, and the recurrence rate is quite low. So this is the characteristics of the defect in terms of the Chevrel and Rath classification. And look at this. If the bigger the defect, 10 to 15 and more than 15, the recurrence rate actually goes higher. So this basically tells us that you have to tailor fit the defect closure to the patient. So I don't think you may be able to use IPOM Plus for ventral hernias which are more than 6 centimeters in defect size. So why do we do IPOM Plus? One reason is that we would like to reconstruct the linea alba for a functional improvement of the abdominal wall. And because of this, less recurrence, less seroma, there's better cosmesis, and there are fewer adverse events compared to the non-closure. So this is a 60-year-old female post-open cholecystectomy about 8 years ago, I think, and developed a hernia in the operative site. So a V-lock was used to close the defect. The advantage, of course, of the V-lock is that it stays in place when you pull it and it doesn't slip. And afterwards, a coated mesh was put. So some studies between IPOM and IPOM Plus. This is actually not just IPOM Plus. They decide in this arm to resect the sac and do some cosmetic things for the wound. So randomized study comparing the two. The parameters in terms of the BMI and the ASA and the others are almost similar. And if you look at the chances of enterotomy, it's much less with the hybrid group. The rest is comparable. And if you look at the seroma rates, this one, the data here, the wound infection, mainly the seroma rate is much less in the hybrid group compared to the IPOM alone. So the conclusion in this study is that when you resect the hernia sac, and combine this with fascial closure, it actually carries a low risk of enterotomy and, of course, a diminished seroma formation compared to the laparoscopic repair alone. So what does the guideline grade B when you restore the normal anatomy? It's actually recommended if you can do it. In case there's a high tension in reconstructing the linea alba, then you may add some form of component separation to close the midline. And in large hernias, you may have to add chemical component relaxation with Botox, PPP, or use of intramuscular expanders to try to facilitate closure of the midline. So of course, if you're going to compare as well closure and non-closure in terms of adverse events, this meta-analysis published in the Ventral Hernia Guidelines in 2018 also favors the closure of the fascia as compared to the non-closure. This is another study, different study looking at closure and non-closure, and we would note that in terms of seroma formation and recurrences, the closure has an advantage over the non-closure. Some words about mesh overlap. Gone were the days that we used the 5 centimeter rule regarding the overlap. What is recommended now is that you have to use the mesh area to defect area ratio, and this should be at least 16:1. In other words, the radius of the mesh used should be at least 4 times the radius of the defect. And as the defect size increases, of course, the size of the mesh overlap should also increase. So in summary, the retrorectus space is the new playground. IPOM and IPOM Plus are indicated for small to medium-sized hernia. Of course, the IPOM Plus is a better result compared to the IPOM in terms of seroma formation, bulging, and recurrences. And the IPOM Plus, of course, has the advantage of reconstruction of the midline, and this may be combined with other procedures such as endoscopic component separation to try to facilitate the midline closure. I think that's the last slide, and I would like to thank you all for your attention.
Thank you, dear sir, for giving us a clear and crisp coverage of the topic. I have 2 questions for you. Now, should you do an IPOM and a closure of the facial defect if it is a non-midline hernia, like how you showed in your open chole?
If you can. If you can.
Right.
Yeah. Because
yes. And
because of the same results, no? Less recurrence, less eventration, and less aroma formation. So if you can, you should.
And
But you have to have the size limit as to what you can close.
and when would you draw a line, if possible? Is there a line to draw between whether you should close or not close? Would
I would
size?
not close, maybe 2 centimeters.
Okay,
Very
right.
small hernias. More often than not, I will definitely close.
Right.
As to how big I will close, my limit is probably at 6 centimeters. More than that, I would probably hesitate, because studies have shown as well that if you do a bigger one, they tend to tear. So that's it, basically. So I usually won't risk, and I will use some other form of repair if I'm dealing with a bigger hernia.
Thank you, sir.
I ask you, there is still any indication for IPOM in the advent of IPOM Plus? Dr. Failona?
I would say very small hernias, only for very small hernias. I would rather do an IPOM Plus rather than an IPOM.
May I make a question?
Yes, Flavio.
Good to see you, Marky. I could not agree more with 2 of your statements that I just want to stress out. First of all, is that you stress that rectus diastasis needs to be addressed at the same time for those smaller hernias. That's something really new for us. Until a couple of years ago, nobody was really discussing approaching those hernias, that diastasis at the same time, and I think it's so important. And then second, that I couldn't agree more, is about the hybrid procedure, something that surgeons may see as a failure once you need to do an incision. Is absolutely not a failure. Myself, when I have a difficulty IPOM, I don't hesitate to make a small incision, resect the sac, and close the fascia, and those patients do very well. I don't consider them as a conversion. But I need to disagree with you when you state that the retrorectal space is the new playground. The retrorectal space is the playground for hernia business for half century. It's just a new playground for us MIS surgeons. And that's why we are here discussing, but it's not definitely a new playground for hernia surgeons.
Yeah, correct. I agree, Flavio.
For more large hernias, will you attempt to combine IPOM Plus with some form of component separation to be able to do the cases?
In very special cases, yes. For example, for midline hernias, then you might be able to combine it with endoscopic component separation and try to attempt to close the midline. But again, as I mentioned, the bigger the hernias, I tend to move away already from the IPOM and try to put my meshes in the retrorectus space already.
Any other question?
Okay, gentlemen, thank you very much.
Thank you very much.
Thank you so much, sir.
And we can go to the next topic. Thank you, Failona, as well as Dr. Alexander. Thank you, Naveen. Next, we'll go to the preperitoneal repair is attractive but not popular. Why? It's Dr. Flavio Malcher from USC. I call upon Dr. Anil Sharma, none other than our Deputy Director at Max Hospital, Max Institute of Minimal Access Surgery and Metabolic and Bariatric Surgery at Max Hospital, Saturn, and past President of Asia Pacific Hernia Society. So I'll just introduce Dr.
Well, thank you, Shiva. Can you hear me?
Yes, sir, please.
Okay, thanks, Shiva. It's my great pleasure to be welcoming my friend Flavio toward this part of the world for a change, for speaking on matters close to your heart, Flavio. So, well, Flavio is one of the stars on the hernia firmament today in the world. Flavio has been reporting on a wide variety of issues with hernia, And some of them that come to my mind are the hybrid repair, the SCOLA, they were component separation techniques. So Flavio was, I believe, born and bred in Brazil and has now shifted to Florida, USA. So well, perhaps the loss of Brazil is the gain of the United States of America. But anyway, Flavio, welcome to this seminar. Welcome to be addressing our friends on this side of the world. And I, in fact, forgot to mention Flavio also runs the Hernia U, which is a fairly popular training course in hernia repairs that is being supported by the Bard company. So the floor is all yours, Flavio.
Thank you. Thank you so much for the kind introduction. I don't think that Brazil lost once I left. I think that right now I face more opportunities, and I'm super happy to be able to produce more using what US has to give us and just extending what US bring to our life as well. But anyway, it's a pleasure to talk with my Indian friends. I've been there twice. I was supposed to be there this year. With all this that happens in the world, I was not able, nobody was able. But let's see what I can bring to you all about preparatory repair. Those are my disclosures. For sure, I'm going to talk about some meshes, about some robot systems, so you all need to be clear on this. But actually, my two big disclosures for these lectures are Conrad Ballasser here from Phoenix, and Cristiano Klaus, my dear friend from Brazil. They kindly share with me some videos and some thoughts, and I cannot start this without giving them the adequate recognition. For sure, we start with Marky talking about IPOMs, and we have a spectrum of options that it can go. Now I'm going to talk about Preperitoneal approach. We have the subcutaneous approach, and we have not the new playground, but the retroactive space as well. So it's interesting to understand this spectrum of options, and I think that's the real idea behind this webinar. So I'll start sharing some tips and tricks to how to do a ventral tap. To be honest, I don't do laparoscopic ventral taps. Right now in my practice, when I want to do a ventral tap, I do a robotic case. Maybe I'm too lazy for a laparoscopic tap ventral. So most of the tricks that I'll show you comes from Conrad. That is my real mentor in this procedure. First of all, understand what is easy and what is not easy. It's always easier in the midline and the very lateral aspect of the abdominal wall. The transition behind the rectal sheath itself is not an easy place. Conrad has talked too much about this, and he refers to RBP, is retract, you give your tension, you bust a little bit with the tip of scissor, and then you push. I rather push up than down, but it's still the same concept. Retract, bust, and push. Retract, bust, and push. That's why I keep telling my fellows and my residents when they attempt to do those procedures, all the same: retract, bust, and push. So a maneuver that personally I like a lot is what I call swimming, and it's a breaststroke swimming. I do this in lap TEPs as well for inguinals. Just put my non-abdominal hand, buzz a little bit, and then you swim, you push up, you open your instruments. It's always the same maneuver. Another maneuver described is sweep down. When you are on the fatty tissue, that works so well, but when you are outside the fatty tissue, does really not work that well. So be caution when trying to use sweep. Fat, as I say already twice, is our friend. So always look for the fatty pads, and when you have a fatty pad, you may be a little bit more brave and you can sweep more, but usually the problem is when you start saying lateral, they're very thin peritoneum. So when you encounter this, you need to change your tactics to try to go to a transversalis fascia plane and invade a little bit the abdominal wall, not the posterior sheath. Is not, we don't want to do a retrorectal repair. That's maybe a bailout for you, but usually I try to go to the preperitoneal versalis. So you see, for example, this case, how many holes I already have on the posterior thin peritoneum, and we try to invade the abdominal wall a little bit, and now we have the preperitoneal versalis fascia plane. That may save your procedure. Again, it's the same idea. Just go to the wall and try to get a little bit of extra plane, and then you have a more resistant, and now you can just keep swimming. I think the key is to create big pocket. Don't be lazy. You need a big pocket to put, first of all, a big adequate size mesh, and second, a big pocket will help you to close those little holes because it will give you more laxity. And at the end, you can put a big uncoated mesh with minimal or non-fixation. So this is my own video. This is minimally edited. I put this needle at 5 centimeters from the midline just to locate myself what is a good place to overlap the mesh. This is not a perfect spot to start, but you can see that even with thin peritoneum, you can start. This is another maneuver that I like a lot from Roxanne Liu. You go deep and then you come back. You come back with your scissors and you dissect towards you. So once I reach the fatty tissue, it will be so much easier to proceed. But until I reach that fatty pad, I need to be more cautious. When I reach the fatty pad, is a faster procedure. We can just start dissecting and reducing the hernia. It was a pretty 2 centimeters small umbilical recurrent hernia. So dissecting, reducing all the content. Now my second space that will be hard is my contralateral side. I use the ruler all the time on my procedures. I want to be cautious of my space that will be big enough, but not too big. So I measure myself all the time. Now it will start to get more difficult that I'm reaching the contralateral thin peritoneal area. But little by little, you create your space, pushing up the wall, buzzing, retract, buzz, push. Once you have enough space, close the defect. Even the tiny small ones, probably we don't need to close, but I have as a routine to close all those defects. Once the defects close, for those small defects, I use ProGrip. I think that for those 2 or 3 centimeters defects, even if it's a polyester, one may argue there's a lightweight polyester, tiny small defects, I think there's enough. This is a 12 by 12 centimeters trim ProGrip. And doing four-fold technique, little by little, you can open. And now it's just a matter to make sure the mesh is quite in place. If you don't think that the ProGrip adhere well to the wall, you can put some 4 cardinal stitches, and that's it. You don't need too much on that arena. And at the end, you just need to close your peritoneum. For me, when I try to do this by laparoscopy, this is the most difficult step. And I just want to stress to you here, there are 2 options. You don't need to close the edge with the edge. You just need to close the space. So you can do before the edge to avoid tension, or if your mesh is a little bit over the edge, you can suture the inferior lip superiorly to the upper lip. There's no issue. You don't need to do edge to edge. Just be cautious of that. Okay, so that was one of my procedures. And this I borrowed from Cristiano just to show you this is possibly by laparoscopy. It's just more labors. You need to use more laborers to do it. So he used a lot of hook as I do in laparoscopy. Just be very, very patient to little by little create your space. You don't have the retraction of the and articulation of the robotic instruments, but you can do straight sticks. It just your ergonomy is not that good. Reduce the sac, create your big pocket, as mentioned before. It's the same surgery done by traditional laparoscopy. At the end, you need to close the defect and close the holes on the peritoneum. For this example, he got a big hole on the hernia sac itself. And then close the defect. It was, again, as the same example of mine, a 2 by 2 centimeters defect. Is more laborious to do by laparoscopy, and just put on his case a traditional polypropylene mesh. You can do tackers, or you can do just cardinal sutures and then just close. This is really a difficult step on the procedure. Cristiano is a lefty. He's a left-hand surgeon, but he really can operate with both hands and very skilled surgeon. This is videos from Conrad. just to show you, off midline, there's still is still an option. You, I'm sorry. We can do, this is recurrent Spigelian hernia. It has a prior IPOM repair together with right groin. You see the prior IPOM mesh, the recurrence, and down into the pelvis in the groin area, it had recurrence. Again, preperitoneal flap as big as you can. We know that probably the sac cannot be reduced. You'll be transected. You get your retroperitoneal space wide open. And then you need to, once you have enough space, you can close the defect and usually would use a V-lock suture, transect the round ligament, what is it, as I do in females as well, and put your mesh, in this case a regular polypropylene mesh, minimum fixation. Posteriorly, you can use some glue fixation. He's tying to the Cooper's ligament, and that's the mesh, pretty open, wide mesh cover. And he likes Arista for hypostasis and seroma prevention. And to finish this, I want to show another case from Cristiano, just again off midline, is a primary lumbar hernia, a Greenfeld hernia. I think those cases are great for transperitoneal repair or a total extraperitoneal repair, but I think the transperitoneal is easier to accomplish. So you see the patient is lateral position, the column is hanging medially because of the position of the patient. Just open a wide space. You can see the small hernia, only retroperitoneal fat herniated. Is under 2 centimeters defect, but very symptomatic. Measuring your overlap, close the defect with V-lock once more, and put a 10 by 10 centimeters mesh. And he fixated with a couple of sutures. Really on the retroperitoneal, I don't like to put anything traumatic. I just use glue or nothing. On this case, I think it's a good case for ProGrip as well. I have a couple of those done by robotics, and I always use ProGrip on those cases. And then let's close the defect, and he's even closer with regular PDS, not even V-lock. So to end this, I'll say that from my idea, from my mind, the ideal cases are those small and medium-sized hernias. Primary incision hernias are not that easy. You encounter a lot of fibrosis when doing incisions. Suprapubic are great to have a decent space, as the inguinal hernias we can do. Subxiphoid, subdiaphragmatic as well, have the fat pad, and off midline for sure. Everybody says that easier in obese patients. I don't know if I agree with that. It's easier when a patient has a thicker peritoneal. I've seen thin patients with a thick peritoneal and extremely obese patients with a very thin peritoneal. So I don't think that I really agree with obese patients. But why? Once it is so attractive, as I just showed you, is an extraperitoneal mesh, don't have all those possible problems of IPOM. You can use a cheap mesh with minimum fixation. You don't disrupt the posterior sheath as you need to do an E-TEP. You can do virtually anywhere on the cavity. Why is not popular? It's easy. This is an easy answer because it's not an easy operation as is an IPOM. You really need to be in the mood to do one ventral tap. I need to confess that every time I schedule a ventral tap for me, I think, oh boy, I need to do a ventral tap. It's not like those easy in and out procedures. Looks great on the videos, but once you are there operating the patient, you need to be very cautious and very patient. And at the end, you see you have your holes, you need to close your holes. So it's a much easier procedure in the paper or in the presentation than in real life. So again, respect the learning curve. I think the easiest will be IPOM, the hardest will be the extraperitoneal approach. TAP, ventral tap is in the middle of this, but it's really feasible and cheap. What for us that comes from not rich countries is a good and very attractive approach. So that is the final slide from Conrad. He has his motto that I'll tap that, and he does for almost everything. But to be honest, he has been changed for the last month. I see more and more E-TEPs on his videos. So I think he's finally recognized that a total extraperitoneal approach is interesting. So as I was introduced in the beginning, I leave here the invitation from Hernia U. Is a complete free platform open to all of us. I think it's a great tool to the junior surgeons that if you can invite them to join. So thank you so much, and I'll be very happy to answer any questions.
Well, thank you, Flavio. That was a wonderful presentation, very crisp, very precise. and you have put in a lot of messages in a short presentation. And for me, I think the were nail on the head was when you said that when you have a ventral tap to do on your list, it feels like a problem, and we feel quite the same, Flavio. So so this is much better, sort of conceptually than practically. Just one or two quick questions on the technique, Flavio. When you do this with straight sticks, with the so-called conventional laparoscopic instruments, where do you start incising from? Do you go down the left flank, or you start more towards the midline, so that you can in fact get that preperitoneal fat that makes dissection slightly easier in the midline, and then come laterally? What do you follow?
Yeah, the few cases that I try by straight sticks, traditional laparoscopy, I start very lateral, and it's really hard. The idea of starting on the fat pad and coming back is great, but with straight sticks, it's really hard to dissect backwards. I use that a lot on robotics, but on straight sticks is hard. One option is you start oblique. You start your camera port on the left upper quadrant. You put your right hand or your left hand on the left flank, and you put kind of almost a subxiphoid to the lateral to your right hand. So you have an oblique approach. So you can start more in the fat, and you dissect laterally to your left, towards the left of the patient, and to your right or to the right of the patient. But to be honest, you really need to be in the mood to do a ventral tap. I would advise you to use it for spigelian hernias. Spigelian hernias are great for ventral tap. For small primary lumbar hernias, that are great. Small suprapubic, great. Small subxiphoid, great. But the midline, try to choose the primary small umbilical hernias, 2 and 3 centimeters, or pediatrics, and just be patient. You need to be patient. Don't give up when you got your first hole, because you're going to have several holes. I have 2 bay out operations for those. If they are really hard and I just give up, actually there are 3 options that if you can give up. 1, leave the holes open and put an IPOM mesh, and then just tack the peritoneal back against the mesh with all the holes. That is not an issue. Don't leave just a space between the whole peritoneal and the mesh. The second option is invade the rectus sheath and do ribs. That's the second option. The third option, maybe the easiest one, is just to convert it to IPOM.
Yeah, so I think, Flavio, the first few videos that you showed us were quite demonstrative, because they show that this is a procedure which is ergonomically quite difficult for a surgeon with straight sticks. That's why the first few videos that you showed us were all robotic. So the key there is to explain that this is a procedure that is quite sort of ergonomically difficult with straight sticks. The second question is, Flavio, like you mentioned, several times in your presentation, that you will tend to make multiple holes, sometimes in the peritoneum, and that happens. I mean, in some patients, you can have a very thin and a very fragile peritoneum. So in these patients, would you still use a plain polypropylene mesh, or would you in fact use a coated mesh once you have made holes? Because one of the advantages of going through the entire trouble of a TAPP is that you can use a plain polypropylene mesh and so save a lot of money. But then, like you also said, with this procedure, particularly when you're starting off, you do tend to make a lot of holes in the peritoneum. So are you still happy using a polypropylene mesh, or the surgeon has to be prepared to use a coated mesh when doing a TAPP repair?
Yeah. So I wanted to show those little tricks, and at my practice, I do all robotics right now for the ventral taps. But I love the title of this presentation, because we see those ventral taps on meetings and everything looks great. And you say, oh, that's a nice operation, I'll do it. I don't need to worry about crossover. I don't need to worry about this and that. And then you go to real life and you get so frustrated that you try to do what you saw in the video and it's just so hard. So I love the title again. And I think we need to be honest. That's a cool operation, but it needs to be understood, and don't get frustrated. Back to your point, if you have holes in the peritoneum, I have this in Brazil. We don't have all the times IPOM mesh available, so we need to bail out somehow. So I try to close. First tip for closing peritoneal holes, create a big pocket, because you have a floppy peritoneum, it's easier to close the peritoneum. If you don't have a big floppy peritoneal pocket, it's harder to close. I try to close. And if you can close all the holes, I don't see why not to use a regular mesh. If you do have IPOM mesh, you can use it. But the tip for me is, I don't know if you can see this, but if you have those little holes, you can imagine that my rectangle is my mesh, and I have those holes. I just put the mesh and attack around the hole. I just want to seal the space between the mesh and the peritoneum. I don't want to leave a dead space, because when you leave a dead space, you can have a internal hernia. So now you're using IPOM mesh. There is no issue. The contact is not more an issue, but the issue is the big pocket you created. So I like to put IPOM mesh, but just tack back the peritoneum against the wall, against the mesh and the wall, to kill that dead space.
Right. Okay. I think that's the time that we had for our presentation, Flavio. So it's back to Siva. Siva, thank you for in fact having us all here on this webinar. You are doing a great job as always.
Thank you, sir. Thank you. I think so. There is a from questions from delegates. There are two questions to Dr. Flavio. Hello, Flavio.
Oh,
yes, tell me.
Yeah.
Oh, Flavio is still there.
Still there. Yeah, there is a two question from our delegate. What
sure.
are being used for the repair of the defect? One. And how to manage pro-grip mesh to prevent it getting stuck to the other areas?
Can you say again?
What sutures are being used for the repair of the defect?
Again, it's easier to use barbed sutures. So I do use 0 V-lock or number 1 V-lock, but Stratafix can be used as well. It's extremely hard to close those defects with non-barbed sutures because of the tension. And the key is a good needle. So you need to have a CT type of needle and understand how to do backhand suturing. Is for us abdominal surgeons, always backhand. And the second question?
How to manage pro-grip mesh to prevent it getting stuck to the other area?
Yes, pro-grip, I enjoy pro-grip for those small defects. I like the 4 folds technique. So I got the pro-grip. The grips are outside. I fold it. In 4 folds. So I open little by little. See 4 folds? So I open little by little. I put closed. I touch the wall and I start open little by little until I have the full mesh open. I don't roll the pro-grip. You'll be a nightmare. So you fold in half and then in half. That's 4 folds. And I mark the mesh. I don't know if you notice, I mark the mesh so I know where's the midline of the mesh. I touch the mesh against the midline of my operative field, is usually the defect, and I start open little by little the mesh.
Excellent, thank you. At the same time, like even though we are discussing, I don't want to leave any delicate question like unanswered. Is Dr. Pailona still here? Dr. Pailona? Yeah. There is a 3 questions for you. It's what is the recent guidelines of lap hernia management in COVID pandemic? This is a topic which you asked me first, right?
Again, can you repeat the question again?
What's the guidelines of lap hernia management in COVID pandemic?
Here in the Philippines, our society actually gave guidelines in the use of laparoscopy for the COVID pandemic. You just have to have the precautions for the aerosolizing procedures, like because most of our laparoscopic procedures are done under GA. So while the patient is being intubated, you have to stay out of the room, and then you have to follow the necessary precautions for smoke evacuation of the gas, and all those things. So we follow the same principles as recommended by the SAGES people in terms of safety of laparoscopy for this COVID times. But in our hospital, we haven't done much yet laparoscopic procedures because the patients are actually afraid to go to the hospital, because our hospital is a COVID center. So they normally will just go if it's an emergency. But otherwise, most elective procedures at this point here in the Philippines, although we're starting to do our electives already, but our percentage is down to maybe half of the usual work that we do.
Thank you. And other next question is, does the hernial sac need to be dissected in IPOM plus?
There are 2 schools of thoughts. The hybrid procedure, the hernial sac is dissected out because it has been proven to decrease the seroma rate. So it depends. It depends. You can do it. You may not do it. It depends on the possibility of having more seromas later on.
It's a small other question, like, is there any advantage or disadvantage on using the mesh with double folding, like 13 to 30 size folded into 13 to 15 size in reverse TOPA or TAR repair or in any other repair?
I don't understand. Reverse folding?
Can we fold the mesh like 13 to 30 mesh into the fold it into like double folded mesh? We can, if you are using this, we have any advantage or not?
I don't think there's an advantage in doing it, because the mesh has been designed already to withstand the intra-abdominal pressure.
Exactly. Exactly. That's that's why we are using the macro 4 or micro 4 thing. Like, there is no need of using the double folded mesh here, right? I think so. This is the questions from delegate for your both of you. I think we can go to the next topic. SCOM, what is the real advantage? Subcutaneous onlay mesh repair or swallow, what is the real advantage? I think so, Dr. Ramesh sir, you can introduce your speaker.
Oh, hi, Shiva. I don't think you... M. Ramesh is there. M. Ramesh is there, or am I supposed to...
I'm here.
Oh, yeah, Shiva, M. Ramesh. Okay, yeah.
So...
Sound.
Yeah, am I audible now?
Yes, sir.
Yeah. So, so we're getting into a very interesting topic of SCOM. What is the real advantage? And I have to actually try to introduce Shiva. So it's like, I don't know, introducing whom to whom. So Shiva has been very well-known laparoscopic surgeon of the South, and he has really come up in the field of laparoscopic surgery. The first time that we came to know him throughout the country was when he started talking to us about transoral thyroidectomy. So nobody could even imagine that things like this could be done, and he came to the national scene doing all that. And he has been executive committee member of the IAGES and the Hernia Society of India. And he has been doing a lot of interesting things, especially innovating things that could make everything cost effective. So he's looked at the SCOLA was one which he was one of the pioneers in the country. And then the same with SCOM. I think SCOM was something that I learned from him. I mean, I'm trying to introduce my teacher here. So Shiva has done a great amount of work to actually tell us about SCOM, and he has really gone all over and spread the message of all these new surgeries. And with these small words, I think I would like Shiva to take over and then tell us more about it.
Thank you, Ramesh sir. Who introduced me is Dr. Ramesh. He's the Vice President of our South Zone, like my zone, like Kanyakumari, as well as he's a Senior Consultant and Head of the AV Hospital, Bangalore, and Director of West Institute of Bangalore. Nice to hear from you, sir. The good words. Like I think so, I'll just straight away go to my topic: subcutaneous on-limb mesh repair. See, when we see a small hernia in the umbilicus, there is a 2 centimeter, 3 centimeter, 4 centimeter hernia in the umbilicus. Like what we are doing still now, like when we are going for the IPOM or IPOM plus whatever it may be, the cost factor, what we are thinking from my person from the like a rural area, the cost factor, how much we are spending for this. See, there is, even though we have so many layers of the mesh placement, like onlay, inlay, sublay, underlay, and intraperitoneal IPOM mesh, we have the neo technique to reduce the cost factor in such a way, to reduce the cost factor behind the surgery, avoid the need for of the costly mess, avoiding the need of the tackers, giving the benefit of the IPOM at very minimal expenditure, and extending the better cure for the poor at affordable cost. What are the steps like what we are going to follow in SCOM? Like I think so, I can go directly into the surgical position. Like this is a position where we stand. The surgeon stands to the left of the patient. Only thing in a SCOM, the position of the patient is the hands are like spread over side the side laterally. On the camera, like surgeons who stand in the left of the patient, in the flank, like camera person to the right, left of the surgeon, and the assistant staff is the right to the patient, and the monitor to the right of the patient, opposite to the surgeon. The port positions are, first is the 10 mm port. Where we are going to place the 10 mm port is the mid-axillary line, where like first 10 mm port is we are going to place. Like then is the second thing is the mid-clavicular line. That's a 5 mm port. Like right and left port is going to place. Now, can you see the video?
No, Shiva.
You didn't see the like even slide presentation?
No, the slide is gone. We are seeing your image. Yeah. Yes.
Yeah.
Yeah.
So this is the patient like with a small umbilical hernia. You can see where I am going to put the port. First port is the anterior axillary line. It's a 10 mm port, which I created. Then like using a S retractor, like our Langerhans retractor, whichever we are familiar, just go to the rectus seat, like or like a external oblique muscle where it will be coming there. You can see the white glistening layer. Just take the trocar, like oblique trocar, and slide above the rectus seat and just behind the subcutaneous plane. Now where you are entering is the subcutaneous plane, fascia scarpa. Just dissect from there like with your 10 mm 0 degree scope. To and fro 10 mm with your 10 mm degree scope, like to and fro approach, like with the 16 mm pressure, high mercury of pressure. You will be creating a plane in a subcutaneous plane. Then like introduce your 5 mm port in mid-clavicular line, right side, under visualization with the 0-degree scope, or like you can change to the 30-degree scope. So now we can use like both hand. We can use any energy sources. Like you can use a bipolar scissor or like monopolar scissor, harmonic scalpel, whatever you want. This is my baby. This is my first case. So I was using here like even the harmonic scalpel or vessel sealing. You too, like I was like had a fear like I should not create a seroma or like bleeding into the site. It's the first case which I am presenting to you. I just come across around like 50 to 2 cases now. Still, like I want to do it like this is the first case which I am presenting to you people. So like in the first case I was fear, like now I use hooks or bipolar scissor, whatever like it's available. Now like created a plane, like you can see in a subcutaneous plane, like the umbilical tube is coming, like that is the hernial sac will be coming. Like this is a place OT plane, like how I'm working on. Only problem is here, like the port place. Port is like somebody should hold, or like we should like do a suture with 10 silk or something, because it's intent to come out, because like only the subcutaneous tissue is going to crash the port. Otherwise, we have to use the screw type of port. So creating a plane just above the rectus seat, right to the sac and left to the sac and posterior to the sac, like. It's all around the sac, around 15 centimeter, like we are painting the sac. You can see nicely now the umbilical tube here. So now I'm going to create here, like going to dissect the hernial sac. You can see the 2 videos, like there's 2 different cases. Dissection of the hernial sac, opening the hernia like a rectus seat, and reducing the content into the peritoneal cavity. It's the first case. So like my staffs are like helping me to like the port should not be coming out. No, so first trial, like they are helping me grasping the port. This is a thing you can see, like how the plane is created. Now like I'm just reduce the sac content inside. Now transfixing the sac with the 2-0 vicryl. One side you can see I am reducing the content. Other side you can see in the left side you can see the how I am transfixing like the sac. After that, disconnecting the tube or umbilicus from the sac. Now closing the defect. Like it's the same like open surgery. Like it's a duplication of open surgery. How we are creating the subcutaneous plane and doing the anatomical repair, keeping a mesh. Only thing here, like we used to keep around 15 to 15 Prolene mesh for like around 3 to 4 centimeter. Even you can keep it smaller also, like something. Then it's a fixation. Like you can do a continuous fixation, but like here, like in a SCOM subcutaneous only mesh repair, I used to do an interrupted mesh like fixation using a 1-0 Prolene. Only thing in these cases, like there is a chances, like in the open case, how we have the seroma formation, same thing, there is a chance of seroma formation. We should be careful here. Then like I'm just fixing the umbilicus to the mesh or the rectus seat to create the umbilicus again. Like we should be careful here. We should not take it into the skin. Only thing, because like then there is a chance of like necrosis of around that place. So what is the advantage here? It's a near duplication of the open procedure, earlier learning curve, and easy plane to work. It's reduce the risk of bleeding, and virginity of the peritoneal cavity is maintained. Reduce the risk of visceral injury and reduce the risk of operative, post-operative infection and minimal post-operative pain. So the conclusion for the subcutaneous only mesh repair is innovative and technique and aim to providing the same efficacy of IPOM at considerably low cost without any technical compromise, thus promising to be an relatively affordable and easily acceptable procedure. If like, thank you very much. Like I think so. Like I completed the.
Yeah, Shiva, this was a very lucid presentation. This is something that it's almost like doing open surgery by laparoscopy. So I would just like to show you uh, well, one small presentation that I have with me. Can I share that?
Please, sir.
So this is one patient where I thought I should talk to you about. This is a patient who's had an IPOM repair. He had a small umbilical hernia, primary hernia, and then he had a recurrence of hernia, ventral hernia after an IPOM plus repair. You see all the scars over here. He has these are the fixation scars of the mesh, and then here we have these scars of the ports. And after 1 year, he comes back with a recurrence. And I felt that this was a very ideal case to do a SCOM. This is the first case that we started doing a SCOM. And then once we started, what I would like to insist is keep a high pressure. And then what also guides us is the trans illumination that you can see here. So once I have a port, I start going towards the other port, make a large window there. And once I have reached there and made a window there, then the two ports are inside, and then you continue doing what Shiva showed. And as he showed, the steps are very easy, methodical, and then it is very easy to do these surgeries for a primary ventral hernia of small sizes. And as he showed, it is just like doing open surgery, quilting the mesh. And then the other thing that I have been doing is I've been using a drain. The two 5mm ports, drains are kept. And this is something that I wanted to show because I just at the end of the surgery, I put in a port and then saw inside the abdomen. It was a real messy thing. All these years, we would go in and then dissect out all these adhesions. You can see the mesh here, and it's all covered densely with adhesions. And it would have been such a big mess if we had to really do something for like a regular IPOM for this patient. So I think this is one major place where I felt SCOM really helped us. Otherwise, regular SCOM repair for a regular primary small hernias is an excellent procedure, and I would recommend that very much, especially after having done these surgeries. I would like any comments from others.
Yes, sir. There is a question from I think so, Dr. Maki Pailona. Do you put trains, Shiva? Yes, sir. All the cases we used to put a train because there is a seroma formation. Like how the open surgery there is a seroma formation chances in the subcutaneous vein repair. There is a repair chances. The same chances of seroma formation is there. So we used to put a 2 5mm. There are 2 5mm port, and both the 5mm port we used to put a suction train as well as the compression bandage. We use a compression bandage with the abdominal binder with the same time 15 to 15 centimeters. If you are dissecting same plane, you use a surgical mopping pad, fold the mopping pad into 4x4 size, keep it there and put a binder. So the seroma formation is very less chances you can discharge the patient even in the 5th or 6th day.
I would also vouch for that because I have seen in my practice, though theoretically, logically, we feel there will be a whole lot of seromas. We have not seen seromas after doing this. So I think that's a big thing. And I'm very happy I'm here with fellow Manana. I would like to share one picture. This was in Dubai 2 years ago when Felona was the president of the APHS. He gave us the Center of Excellence certificate at Dubai. And I'm happy that he is here to be with us today. Thank you.
Any other question from the...
Yes, sir. I have one. Will your port positions change if the patient has an associated divarication?
Exactly. Like if the diverication is going to be there, we are going to do a SCOLA, not SCOM.
Yes.
What
Okay.
is SCOLA is subcutaneous
So
only.
just for the benefit of our delegates,
Yeah,
can you?
like, this is a topic which I think so. Like the ventral hernia presentation, second parts 2. We presented the topic SCOLA, subcutaneous only mesh repair with the augmentation. The like what we do is the like just above the pubic symphysis, like 10 millimeter incision we create. To that, we create a subcutaneous plane and 2 5 mm port on the both the sides of. Like if you want to see the video, I can just like 1 minute. Like please put the video. Just show how we are approaching. Like because there are SCOLA which is called like there will be at least 2 to 3 centimeter opening in the pubic symphysis like for suturing. But like we never open for like more than the port incision like what we do in SCOLA.
Can I just come in here, Siva,
Please,
till you sort of get your video running?
Yeah,
See, what I want to know is, Siva, now we all know that divarication of recti with a hernia is a fairly serious matter in the sense that this is a condition that needs to be repaired whenever there is a midline hernia. With a divarication, it needs to be repaired. So what I want to know is what is the best way of surgically repairing a divarication as far as the view is concerned. Is it best repaired with an onlay technique or best repaired with a sublay technique? Because my feeling is that with these SCOLA techniques, perhaps you cannot view the divarication that well. Whereas from a sublay technique, you can actually see both the muscles apart and then take sutures under vision. So what do you feel is the better approach? And I'd request Flavio also to come in on this at some point.
So we've been doing rectal diastasis for half century by open approach, and there is no issue on identify the edge of the rectus. You are able to see, and there are some tips that you can do. You just boogie the muscle. If it contracts, you are on top of the rectus. If it does not contract, you are on the linea alba. So it was never an issue. It's a fear that we all have, but actually when you are operating, we can just see the rectus, and I mark them. And the anterior plication, in my opinion, is much better than posterior plication for rectal diastasis because you don't create anterior reach. If you do a posterior plication, you're going to have anterior reach. And that's the way that has been done for half century from plastic surgeons. I have several comments on the presentation, Dr. Silva. I just can't help myself that now I am aware of the 9th name of the same procedure, because everyone that does something different gives a new name for the procedure. And it all started with the French guy Champol that published 1999 Preperitoneal repair of the hernia. And then the Spanish guys got REPA, and then Ed Felix got SCOLA. The European has Tesla, they have Miller, they have Eller. Another guy from Brazil gave another name, Zvat. I cannot even say the name. So it's the same procedure. It's all the same procedure. And I can't help myself to laugh when I see that different names that everyone is given. Maybe someone needs to give our own names of Flavio's plication or Silva's plication, so we can have a definite name for this. We all are from poor countries, and when I see you guys using ligature or using harmonic to do those operations, this is even more expensive sometimes than IPOM mesh or attacker or a Barbie suture. So I'm always amazed how we see those instruments on those surgeons that really is not necessary. As you mentioned, that now you do all with monopolar, that's exactly the same. Seromas are a big issue. We have all those experience. I have my own experience now. I just sent to Sage Surgical Endoscopy to publish my US series of, and I have 27% of seromas. and there is an issue. But besides seromas, there is no wound morbidity. Because the problem with onlay meshes is when you have a wound dehiscence after seroma, or in fact, and you expose the mesh. That does not happen on those endoscopic approaches because you don't have a wound to heal. It's completely different to have a seroma with a wound on top of it and have a seroma without a wound. So we need to recognize it's an issue, but it's a minor issue. Something that I have with my patients, some numbness. I don't know, maybe you can comment this. Does your patient, they complain about abdominal numbness after the surgery? And my patients, they complain. And my last comment is, if I can give you one advice is, do more fixation. Only meshes, they don't have anything on top of it to hold in place. So every time I do a SCOL or a SCOM, or whatever you want to call it, I'm really neurotic about fixation. So I quilt the mesh, I do outer suturing because that's what I do on open onlays. I'm just afraid with less fixation, that mesh can displace itself in the future. But I enjoyed the videos. Thank you so much for showing us.
Shiva, would you like to comment about this? What is your feeling about SCOLA, and is that better than the posterior repair?
Like even we do the posterior approach from down, like we used to do the rectus seat approach initially. But what I feel nowadays, like after doing the SCOLA, SCOMA, this is the better approach. Like how do we see in the open approaches, like the results are more clear because the suturing, like the midline, preparing the linea alpha, reforming the linea alpha in the midline is more comfortable in the SCOLA. But that's all I can see. Like you can do it in 2-layer, or you can do it in application single layer using a 2O ethylon, or like you can use this one like pod sutures, like with the 2 layers. So like that's going to give a nice result from the pubic symphysis to the syphisternum is going to be the better result. As like Mackie, Calio asked me like regarding the using the harmonic or like, that's why I told like the first case, when we are doing a first case from my side, I got a fear, like I should not get a bleeding, I should not get a seroma. That's why we use such a costly instrument in initial status. But like when we are doing now, the cost factor is coming down, like using a monopolar, bipolar, only pulling mesh, we are going to, not all the cases of selective cases, not for the each and every cases we are going to do a SCOM or SCOLA. This is a selective case, poor patient with a small hernia, without adhesion, like just you go for a SCOMA, and the initial surgeon who is doing an open surgery, they want to convert into the laparoscopic surgery. It's a like easy process to convert from the open surgery to the laparoscopic surgery because the learning curve is very low, as well as it's easy procedure because it's just duplicating the open surgery into that. That's all I can say. Because like I'm not saying I'm only doing the SCOMA or SCOLA. We do all the procedure from the down to have all the procedure, but selecting of the cases is important in each and every cases. It's depend on the place where you are and the thing. Thank you.
Well, I have 2 questions for you.
Please.
One is, does the skin vascularity get compromised when you are doing this? Because when we do open onlay mesh repair, often when we mobilize the skin and subcutaneous fat, the edges of the incision get necrosed, or the vascularity is compromised. So do you get any vascularity compromise? And what is the difference between SCOLA and SCOM?
Shiva, would you like to say something about this? About skin avascularity, especially when you dissect out the umbilicus, would there be any necrosis of skin? Have you seen that either in SCOLA or SCOM? See, now I would like to give my own experience. I've been doing these 2 procedures for the last 2 years, and I've got about 20 cases of SCOLA. Especially I do this for postpartum ladies who have small umbilical hernias but a huge rectus divarication, and then who also, many of them have a low back pain. And once we've done a repair, we've seen that they've done really well. My first case.
At the same time,
yeah.
I think so. Like my one line is got like disturbed. Okay. Can you hear me?
Yeah. Yes.
Can you hear me, sir?
Yes. I can hear you. Yeah. Please, you can answer, Shiva.
Yes, sir. So, like the skin necrosis, we can be avoided like when you are sustaining to the fascia scarpa. One. And other problem is like where there is a skin necrosis chances is nearby the umbilicus. When coming to the umbilicus, like using like if you see like I left over some rectus seat around the umbilicus, like I didn't go to the skin level at all. If you are going to the skin level, still there is a chance of skin necrosis in the umbilicus. And like Dr. Flavia told about the skin numbness. Yes, there is a chances of skin numbness in cases if you go away, like too away from the lateral part, like around like more than 12 centimeters, 15 centimeters, there is a chance of like skin numbness, as well as like if you are like even small part, when you are going for the like subcutaneous pain like thing, there is a chance of numbness, but that will recur like you will be normalized like maybe within 1 month, like 15 to 1 month. That's all.
And what's the difference between SCOLA and SCOM?
Sir, that is SCOLA is like it's a subcutaneous online mesh repair with the augmentation of the rectus seat, where we are doing creating the linea alpha, newer linea alpha, getting the whatever the rectus seat is given away from the midline, you are just bringing it into the midline and creating a linea alpha. That is the augmentation. In SCOM or SCOM, it's a subcutaneous online mesh repair only for the umbilical hernia. With the umbilical hernia, with the divagation of recti, what we are going to do is a SCOLA.
Okay, thank you.
So I think we've had an interesting session. Shiva has mentioned everything nicely. As for what I have seen were the comments about using harmonic scalpel. All of us start doing that in the beginning, and all of us have converted to monopolar and bipolar later on. So even I do with my left hand, I have a bipolar. In case there's a bleeding, I use it, or I just use it as a grasper. So definitely there is good cost effectiveness, and I think we've covered rest of the points. Thank you very much.
Yes, sir. Thank you very much. I think so. Like we can jump over into the next case. As a E-TEP, is it too much for the too little hernia? It's interesting by Dr. Rahul Mahadar from Mumbai. Dr. Avinash Katra. Hello.
Can you hear
Dr.
me?
Avinash, your microphone is muted. Could you unmute yourself?
Yeah, it's unmuted.
Yeah. Hi, good evening, friends. We welcome to the next topic.
And thoracoscopic and general and endovenous surgeon. He's a zonal executive member of HSI of West Zone, and he works with PD Hinduja Hospital as a medical research center, as well as the Hinduja Health Surgical Center in Mumbai. Nice to have you here, man. Like, just introduce your speaker. Thank you very much.
Yes, thank you, Shiva. Yeah, good evening. Yeah, we come on to the next topic for the evening, E-TEP. It's obviously a very hot topic of discussion over the last few years. We laparoscopic and robotic surgeons have revisited the sacrosanct space of the rectorectus space, which has been used by our ancestor surgeons for so many years before us. The common apprehension is it too much of a dissection for these tiny hernias? And we have a very eminent speaker in Dr. Rahul Mahadar. This is the topic very close to his heart. I can vouch for the fact that he has spent half the lockdown period being involved in various webinars and master classes on E-TEP and hernia repairs. And it will be interesting to have his views on this. He's an established surgeon in Thane and Mumbai, has several hospital attachments, including running his own hospital. And without much ado, I'd like to hand over the mic to Rahul. Rahul, all yours.
Thanks, Avinash, for giving me a good introduction. I'm now sharing my screen. Hello. Can you see me now?
Yeah.
Yes, we can see your slides clear. Go ahead, please.
Okay. So what are the options for treating such hernias? One is the open repair, other is the IPOM, IPOM plus, TAPP, TAP procedure, COLA or SCOM, and E-TEP repair, and the EMILOS. I'm a hernia surgeon. I'm doing all these procedures. But today I'm here in front of you to tell you, E-TEP, is it too much for too little? Now, laparoscopic ventral hernia repair is mainly confined to IPOM and IPOM plus. Now, these two procedures are rapidly adopted by the laparoscopic surgeons all over the world. And it is used to repair almost all types of hernias that every surgeon can accomplish. Now, it is emerged as a preferred or even a gold standard minimally invasive technique for small to medium-sized umbilical and ventral defects. Now, the advantage for laparoscopic ventral hernia repairs, as you all know, is a low wound morbidity, avoids large abdominal incisions, and decreased length of hospital stays. And the basic downside for these particular surgery is the increased seroma and hematoma development, increased intra-abdominal adhesions due to intraperitoneal prosthesis, the persistent bulging in bridging repair techniques, not in IPOM plus, and requiring covered mesh, which is expensive for the country like India. Now, the other downside is the intraperitoneal mesh is often anchored with a transfacial sutures to stretch the mesh and limit shrinkage, and also obviously the hernia recurrence. But transfacial sutures causes ischemia of abdominal wall and are correlated with the increased postoperative and prolonged pain and potentially inside the recurrent hernias. And fixation tackers, permanent or absorbable tackers that are used, which is again add the cost for this particular thing. So tackers are permanent or absorbable. They are correlated to postoperative pain as well as the cost of the procedure. The goal for avoiding intraperitoneal mesh in minimal invasive repairs motivated a hernia specialist across the globe to innovate further. And some surgeons started doing laparoscopic transabdominal preperitoneal tap technique using simple polypropylene mesh for ventral hernia repair with laparoscopic ventral hernia repair, which able to show the cost efficiency. It decreases the seroma formation and decreases the recurrence as well. But it is equivalent pain score as compared to IPOM and IPOM plus, as the mesh is secured using both transfacial sutures as well as stacks. And the other drawbacks for TAP procedure are, it is a time consuming, it is definitely technically very challenging, and significant learning curve. Already all these points are mentioned by Flavio in his particular talk. And inadvertent hole in a peritoneum during the dissection, which are very difficult to close. And it again, if we put the composite mesh or covered mesh, then the cost goes very high. Now, the Reeves Stopa repair is the retrorectus repair has stood the test of the time since it was introduced way back in 1970s. Now, this is mainly used by many open surgeons for the midline hernias since long time, and it is really time tested. Now, this particular technique, why not to do it in a laparoscopic way? Jorge Diaz from Colombia, who has introduced the E-TEP technique for large inguinal scrotal hernias. So this technique has been extended for the approach to ventral hernia repair by Igor Balansky from USA. What Jorge Diaz did is, for inguinal hernia with the standard port positions are in the midline, he shifted these ports way laterally and above the abdominal wall. Igor Balansky pushed this particular ports into way above into the in the upper abdomen or in the epigastrium, and from here, where he dissected the space and till the lateral border of the rectus, and all the space is augmented with the help of the mesh, which is a common polypropylene mesh. Now, the E-Reustopa principles which are followed in this particular procedure are: it's a closure of the defect, which in turn leads to restoration of linea alba. Mesh placement is outside the abdominal cavity and reduces the mesh fixation without compromising the hernia repair. E-TEP ventral hernia is in this particular procedure, what we do is the extraperitoneal balloon dissection or telescopic dissection in retromuscular or the preperitoneal planes. It allows the defect closure and component separation if needed. If the hernias are of a larger size, the defect is not possible to close intraoperatively, or otherwise there are lateral hernias as well. And wide prosthetic reinforcement in a sublay position. Now, port placement is the attack of strategy for E-TEP repair. The correct anatomical plane is to start into retrorectus space, respect the angulation principle, and it allows the best approach to the defect. The port placement, the landmark is linea semilunaris. It is the lateral border of the rectus muscle, and developing an appropriate retrorectus space to place the ports, the subsequent ports. And this allows the best approach to the defect as well as for the dissection. Now the question comes: is the E-TEP is ergonomic? See, if you see the midline hernias and for the umbilical hernias mainly, if you go from the epigastrium, then these two instruments, it forms the proper angulation and ergonomics to close the defect in the midline. As compared to IPOM, where usually the ports are on the lateral aspect of the abdomen, and even though we are dissecting the plane, still the suturing becomes very difficult. So ergonomics is well maintained in case of an E-TEP. The adaptable port positions are possible with E-TEPs. You can see for the hernias of umbilicus and infraumbilical region, you can take the working ports way above in the epigastrium like this, and then you can close the defect and dissect the particular space completely. Or otherwise, for the supraumbilical as well as the epigastric hernias, the surgeon stand in between the leg of the patient and he can dissect in the retrorectus plane, and even the defect is completely closed properly. And you can do a sublay mesh placement. Now, is the sublay mesh is the most recommended? Now, this network meta-analysis suggests that the probability of the sublay being the best location for the mesh placement is very high. And this network meta-analysis also demonstrates the high probability that the sublay repair is associated with fewest SSIs and hernia recurrences. It's closed in case of a E-TEP procedures. Now, is it possible to close the defect all the time? You can see if you do the retrorectus dissection, you can mobilize from one side up to 7.6 centimeters. If you do the transverse abdominal release or dissection, you can mobilize the abdominal wall by 8.9 centimeters. And if you do the retromuscular dissection till the lateral muscles also, then you can mobilize up to 10.2 centimeters. So if you compare the cost effectiveness of a E-TEP, both composite mesh and the tackers are not necessary for the E-TEP repair. And also another advantage is there is no intraperitoneal adhesions. Now, if you see here, this female was operated in way back 2002 for the epigastric hernia by the open retrorectus repair. And she came to me for the laparoscopic cholecystectomy, and I put a port inside. You can see here, the adhesions are very minimal, and at the edge of the mesh, you can see here, and those are very flimsy adhesions. So this is the most important thing as compared to IPOM, because if you see here, in IPOM patients, you can see the seroma formation which got infected, and it is the bowel was adherent to it, and then we have to remove this particular mesh from the abdomen. These slides and this thing has been given to me by Dr. Ramesh Agarwalla from Mumbai, and I'm very thankful to him for that. Now, the suture repair for primary, small, and umbilical and epigastric hernias, the concomitant rectus diastasis is a significant risk factor for the recurrence, has been told in his study by Cochlear. And why he is what he has reported is almost 31.1% relapse in the patient with epigastric and umbilical hernias smaller than 2 centimeters with diastasis of recti. So this is most important. So the main challenges for doing E-TEP procedure are midline crossover is a biggest challenge, and suturing at the roof. These are the main two challenges what I feel in my own practice. But the other challenges are the optical entry to the retrorectus space. The midline crossover is a crucial step and definitely a difficult step. Inadvertent injury to linea alba is done by many surgeons. Even I have done it, but you need to identify that and rectify it on table itself. It is some surgeons have blamed this procedure as a somewhat blind procedures, which can even leading to enterotomy and bowel injury while taking down the hernia defect or hernia contents. And the suturing might be a challenge for some surgeons. And post-operative chances of disruption of PRS leading to posterior sheath hernias. This is the most dangerous thing which can happen with the E-TEP RS. Now here you can see one of the patient was operated by some surgeon, and he came to us with this particular picture, wherein you can see here the bowels are entrapped in between the posterior rectus sheath and the mesh and causing the intestinal obstruction. And immediately we've done this diagnostic laparoscopy, and we find these bowels are entering into the plane. And once after getting down these bowels, you can see the rent, you can see the mesh and the sutures, and the bowels are entrapped into this. You need to see for this, and this is a very emergency condition. You need to tackle it very early, otherwise it will be a disastrous position. Now, E-TEP Reeve-Stopper procedure is, in this particular procedures, there is no composite mesh is necessary. So because of that, there will be reduced risk of adhesions, reduced cost, and there is a less penetrating fixation which is used, or no fixation is used. Because of that, there will be less pain and fast recovery of the patient, and probably one of the best solution for ventral hernia repair as of now. B. Ramanna, he is an Indian surgeon from Calcutta. He has popularized this E-TEP technique for ventral hernia in India and Asian countries. He is coming up with the new advances in E-TEP technique, which is called as the stapled E-TEP repair. Now, this is probably the first ever study is done in India as well as worldwide. I might be wrong, but this is what, from my knowledge, it is the first surgery which is first study which is going on in this regard. Now, E-TEP stapled approach is for the small primary ventral hernias, 2 to 4 centimeter diameter. GI staplers are used to reconstruct the linea alba and posterior rectus sheath, which avoids the suturing at the roof. And it is under evolution and study is in progress. Because of this COVID pandemic situation, it has been delayed, but the study is still going on. And what he does in this particular thing is he uses the GI stapler to put to separate the linea alba as well as the posterior rectus sheath. And if you see here, this is the picture after putting a stapler. But now here he is using the GI staplers. GI staplers are not meant for the anterior abdominal wall. That staplers needs to be evaluated further. But study is going on. We'll see how we can go ahead. But it is the proposed advantage for the stapled E-TEP repair are is approachable to the surgeons. It democratizes the E-TEP procedure and makes it accessible to average lap surgeon. It is very quick and reproducible, and it can prevent the excessive dissection in smaller hernias. And pain scores are very low, and it may help to standardize this operation. Now, if you see the E-TEP disadvantages for E-TEP procedure, they are a steep learning curve. Robust knowledge of anatomy of anterior abdominal wall is required, and it is one should be very comfortable in working in a tight space. And you have to be mindful that there is a bowel beneath, and aware of the possible complications and to manage the said complications very effectively. Now, how to overcome these problems of E-TEP? You have to revisit the knowledge of anatomy of anterior abdominal wall. There is guided mentorship is required, and hands-on courses on cadaver models is a necessity of a time, and careful selection of initial cases, which is must for to start with for the E-TEP procedures. And preoperative marking of seminal line and relevant anatomy is must. And you have to spend developing the proper tricks to accomplish this particular endeavor. What we can cost effective. It is a large uncoated mesh is used, so cost becomes very less. So mesh is kept outside the peritoneal cavity. Low surgical site infections, low surgical site observations like seromas, hematomas, or disruptions, and less pain and shorter hospital stay. And the most importantly is a long-lasting repair. So the future prospects for E-TEP is definitely there. Retromuscular space is a dynamic space. Now we have to revisit this space, and more scope for evolution is there for this particular procedure. In future, we can expect more evolutions and different techniques to do this particular procedure, and one need to standardize these steps so that any surgeon can reproduce the procedure very well. Now, in conclusion, E-TEP repair, it has a place in laparoscopic ventral hernia repair. For the defect size between 4 to 8 centimeters, it's the most ideal approach, according to me. And for the small midline hernias with diastasis of recti, this may become a choice of a procedure. All principles of Reustopa repairs are followed in particularly in this particular procedure. Now, everybody dreamed of this car like a Tesla, which is a need of a time now. But why this is there? It is because of its good looks, fast, it is well built, it is safe, it is sturdy, and of course the fuel economy. But if you see, it takes time to earn, and maintenance is questionable. We don't know, and the expensive to repair, that is for sure. So, do you think E-TEP is too much like Tesla? I think E-TEP can be your Tesla. Thank you very much. At the outset, I thank Dr. Ramesh Agarwalla, President HSI, and Dr. T. Shivakumar to organize this particular program, and all HSI committee members to give me this opportunity to come in front of you. Thank you very much.
Thank you. Thanks, Rahul, for a very crisp presentation. If I may ask you a question, do you have a lower cutoff in terms of size to offer a patient an E-TEP for a small umbilical hernia without any divarication?
Yeah, what I do is up to 3 centimeter defect, or up to, you can say, 4 centimeter defect, primary hernias, not an incisional hernia, but it's a primary hernia. And there is no clinical diastasis, or even on sonography also you are not getting that much of diastasis, because I always ask my radiologist or sonologist to see for the diastasis part of it. And if it is so, then for primary hernias, I go for IPOM and IPOM plus. So not for IPOM, but IPOM plus, definitely. But if the cost is the problem, then I definitely think about the E-TEP repairs. But mainly, according to the size, it should be above 4 centimeters and above.
Okay. And would your size of mesh vary depending on the size of the defect? In terms of the length of the defect? No, the E-TEP. I'm talking about the E-TEP now.
Now, regarding E-TEP, what we do is we do the total retrorectus dissection. Now, for small hernias, what we do is we dissect below the in the midline, below the lower border of the defect. From there, at least for 7 to 10 centimeters, we dissect. We need there is no need to go always up to symphysis pubis, or always up to the ZP sternum if you are going from down up. So there is no necessity, but you can take up almost approximately 10 centimeters on both the sides, laterally up to the linea seminonaris, and that part is measured while doing the before putting the mesh, and according to that we can calculate your mesh. But many a times what we have observed is the size moreover commonly required is almost 24 by 15 or 14 size mesh. That is what is required for these particular repairs.
Okay, thank you. Are there any more questions from the audience, Shiva?
Audience, like for Dr. Like still not the question not arise, but like there are so many questions like.
Any other panelists or faculty would like to ask Ramesh, any questions regarding the E-TEP? Any comments, please?
Yes.
Yes, Flavio, please go ahead.
I really enjoyed the presentation, and I agree most of it, and is interesting. And I'm just afraid of those new techniques. They get fancy and sexy, and everyone want to do it. I've seen real bad complications in my own hospital when some surgeons try to do it. So I think that ribs, we're trying to reinvent in ribs, and I like the idea, but it's really to be to dedicated surgeons to the abdominal wall. I'm not saying that we want to forbid everyone to do it. No, just be conscious and prudent when doing that surgery. I saw the comments on the stapler technique. I have the same feeling that they are GI staplers. They are not designed for the abdominal wall. Maybe a company should work on them and have appropriate staplers. I'm a little bit afraid of this. I really reserve E-TEP when, as Proper said, that will have a diastasis, because I don't like the idea to destroy the abdominal wall to reconstruct it. So if you have a diastasis, I think that is a valid price to pay. But if you don't have a diastasis, I feel that maybe not the best idea to do a E-TEP on my own practice, my algorithm. And just a side comment, ribs fixate the mesh. So most of the surgeons that are doing E-TEP, they are not fixating the mesh. But if you want to study ribs procedure, it does, he fixes the mesh. So if you really want to replicate ribs, you do need to fix the mesh.
Yeah, very valid points. Yes, Rahul, a retort from your side?
As Flavio has mentioned, these staplers are for regarding the stapler E-TEP repair. These staplers are mainly for the GI repairs, but these are not meant for the abdominal wall. But the companies are ready to evaluate, and they need to change the stapler according to the requirement, according to the thrust or the pressure of the anterior abdominal wall, to accommodate that particular thrust. That is the most important thing for holding that particular staples in the place. So they are ready to do that, and he is trying to do for that particular innovations in that particular field. So this is why this E-TEP is having this space, retrorectal space is definitely a dynamic space, and we need to evaluate that further. And as he rightly mentioned, that in an original article of a Reeves Stopa, he used to fix the mesh. But now over the period of time, day by day, we are at the beginning also we used to fix the mesh at the pubic symphysis or at the GP sternum. You can take in the lateral aspect also. But after a few days, then once we accommodated the space completely, then we started not fixing the mesh, and now it is almost just putting a mesh into that particular space and getting out of it. Thank you, Flavio, for giving your expert views. Thank you.
Yes, Ramesh, you wanted to say something as well?
Yeah, I have done a little bit of a modification of this repair. What we do is we do an ultrasound scan, a soft tissue scan, see where the rectus muscle is ending. I mean, we draw a line on the abdomen, and then we just go 1 centimeter lateral to this and enter into the retrorectus space directly with the trocar. Means like an open laparoscopy. And we also use the biggest challenge between SCOM and E-TEP. I mean, what in both these places, Shiva also mentioned about it, is a gas leak. Somebody has to hold the trocar and things like that. So if we have a double balloon trocar which holds it in place, because the support is not as good as going into an intraperitoneal one. And then we have been using only 2 trocars, 5mm trocars, one just around the umbilicus, just below the umbilicus, and then the other one is near the epigastric. So first you create a space towards the umbilicus, and then from there, once you have the trocar inside, you create a space towards the epigastrium, and then go down and create the whole space. And as we discussed, the mesh size is 15 by 25 centimeters. That is what we normally have to put. And it is a very good repair, but it has a learning curve. I should say it has a learning curve. SCOM does not have a learning curve, as Shiva said. But here we have a learning curve. Most people require 4 ports. Most people have been using 4 ports, but then I have started using 3 ports. But I think that there is, as far as my experience, my personal experience, I think it's there to stay. There are certain modifications, and we can do a very good job.
Yeah, so, thanks. Yes, Shiva.
I just have a comment.
Yes, please go ahead.
I'm Ashwin. This is to Dr. Anil Sharma. I know I've seen a presentation from him regarding this stapled retrorectus repair a couple of years back. So I would just like to know what the status was. If sir has given up on it, what is the reason? And any feedback on that, sir?
Yeah, thanks, Ashwin. That was how I personally started off my foray into the retrorectus space. In fact, the stapled retrorectus approach was first described in Brazil. I have met this very pleasant gentleman who had first described this in multi-Paris post-bariatric surgery patients. So this is where this concept first came out from, and we had done a few of these repairs at the Max Hospital. In fact, the main thing, like in fact Rahul said, the main thing that crossed our mind at that time was, is it right to be using this stapler to reconstruct the abdominal wall? Because that is not the purpose this has been designed for. So we started using the black cartridge, actually, the last few cases that we did. But then with the black cartridge also, we had posterior rectus sheath dehiscence. And this patient came back to us on the 4th or the 5th day, and about 50% of the posterior rectus sheath was open. So what I'm trying to say is, like Rahul also mentioned, the current generation of staplers that we have, that we use in GI surgery, we are not certain whether these can withstand the abdominal pressure that is required for a good repair of the linea alba. So I personally I'm still waiting, to be honest. I was quite afraid when I saw that posterior rectus sheath dehiscence. And that to me was a repair where there was not that much tension, on the posterior rectus sheath as far as I saw it. So I am still keeping my fingers crossed, but then we do need surgeons who will sort of venture out, foray out, so that we know what results we have with different techniques that we have today. Rahul made a very good presentation. I think he in fact covered the entire scenario with the E-TEP repairs today, and gave us the entire sort of information in a nutshell. So I am quite pleased, actually. What I also believe, like Rahul said, is that we have to be selective about selecting our patients for an E-TEP repair. There are significant, very significant advantages with the E-TEP repair. It is certainly a step forward in hernia repair, but then this is a repair that comes with an inherent morbidity in terms of the collateral damage that is done to the bilateral posterior rectus sheaths. So what that is the I think reason we in fact need to be selecting our patients and perhaps not be doing it for small hernias of the abdominal wall, like we all seem to agree. 2, 3 centimeters hernias may not be good candidates for doing an E-TEP repair. But then where I see more and more of an E-TEP repair being done is for those patients that have midline hernias, but then with a divarication of the recti. Now we still don't know what sort of divarication of the recti becomes surgically significant. As far as my knowledge goes, we have still not in fact decided about what is level of divarication that needs a surgical repair. Of course, patient symptoms also play a large part, but then for these patients with abdominal wall hernias with significant divarication of the recti, perhaps this repair seems to be very well suited, apart from the other indications, of course, because once you are in this space, you can actually access the lateral abdominal wall by division of the transversus abdominis muscle, so you can in fact create much more space for a larger mesh. So my sort of bottom line for this repair is be selective about choosing this repair for your patient.
Okay.
Thank you.
Thank you. Yeah, Shiva, can I hand the mic back to you for the next panelist session?
We are just running short of time. We'll try to go to the panel discussion. As regarding this panel discussion, the previous academic based on the we had a 2-part of a ventral hernia. In that, we based on the case scenario and the complications of the hernia surgery we discussed in the panel discussion. So I thought this time around I should plan in such a way that the beginners in lap hernia should credited with the maximum share of benefits. So our panel discussion is today program will be based on the basic technique and common scenario we came across in ventral hernia. I think so. All of us, all the panelists, all the speakers, as well as the moderators, will join the panel discussion. Dr. Ramesh, sir?
Yeah.
Yes, sir. Thank you. So, I think so. We can start with the first. Is the routine application of CT and magnetic resonance imaging recommended for the diagnosis of the ventral hernia?
No, I don't think that is.
1 minute, sir. 1 minute. Is there is a routine application of CT or MRI is needed before diagnosis of ventral hernia before the laparoscopic ventral hernia repair? This is the first question for you, sir.
See, we are talking about primary small midline ventral hernias.
Exactly.
And for this, I do not see a role for a routine CT, MRI scans at all. Yeah, it is required when we are looking at more complex situations, like we want to assess abdominal walls which are very thinned out. We are talking about loss of domain. We are talking about a small bottleneck hernia with a huge ventral hernia. Those are the things where probably some of the conditions which require it. Definitely not as a routine.
Exactly, sir. What I'm going to say, this is the we are not talking about here the small hernia. This is a topic we are going to talk for the beginners of the laparoscopic hernia surgeons. So it is accommodated all the lateral and ventral hernias as well as all the hernias are included here. So the basics are there. So like as you told, like this is like for the midline hernia. I think so. Like any other comments, sir? Any other comments from the panelists?
Yes, I do have a comment. I disagree. I think that it's important to have a CAT scan, not MRI, for all ventral hernias. That's what I do in my practice. I like to understand the size of the defect preoperatively. I want to see if there's a rectal diastasis. Sometimes the patient are obese, we cannot really feel the diastasis. I like to see if there is more defects, additional defects. If I'm planning a E-TEP, I want to have the measurement of the rectus width on the CAT scan. So I really value a pre-op CT scan for all my ventral hernias repair.
Any other opinions, sir?
Shiva,
Yes, sir. Please.
actually, I'm totally agree with Flavio, and that is what we do in our day-to-day practice. See, if the hernia size is just 1 or 2 centimeters, then it's okay. You can go ahead with sonography. But anything above 2 centimeters and above hernias, and these are midline hernias or the lateral hernias, one has to go for the CT scan, and not necessarily all the time you should go for the with dye study. But you can do a plain CT abdomen as well, wherein you can know that the width of the recti, the width of the rectus muscles, as well as width of the linea alba, and you can very well recognize the diastasis and where it is actually, and then you can choose your procedure wisely for that particular hernia. And that is what is the most important thing for doing regarding laparoscopic surgery. I feel these newer gadgets are really helpful, and you need to talk to your radiologist too regarding the cost of that particular thing, because that is the only constraint for, that is what I feel, because I'm a total private practitioner, and where the patient is always regarding kitna deti hai, this is the typical there in every Indian's mind. So how much I'm going to spend on it. So that is where you need to talk to your radiologist and do these scans for this thing, and they ask the radiologist to comment on the anterior abdominal wall rather than the contents of the abdomen. That is most important, because no one is talking about the hernia, the muscle size, the thickness of the muscle, the thickness of linea alba. That is what is most important thing, and that is what we have started doing now.
Please, any other opinions?
Yeah, doing a CT will avoid a lot of surprises in your surgery. You might be able to see some things that are not visible on your physical exam. So it will make you more prepared in doing your surgery, and it will make you plan out what to do for your patient. So CT scan is very important.
Okay, so many of us like go for the CT because like for the strong guidelines is CT scan is helpful in predicting the wound complication as well as its need for the complex abdominal wall repair technique, as well as it's a defect size we can measure, and other thing like surgical thing, like whatever you people talked about this like is well taken. So like CT scan or any other like formal of scan thing is important before the surgery. Can the routine application of ultrasound imaging be helpful in detecting the ventral hernia and rectus diseases in preoperatively? Dr. Dr. Anil Sharma, sir.
Yeah, see, like I was saying, this is something we are in fact learning of late to be wary about ventral hernias and rectus diastasis, coexistent in the same patient. I am still not convinced about doing CT scans for all hernias for the entire range of patients that come to you with a hernia. But I can see the value of doing an ultrasound imaging on table to see if this patient has a significant rectus diastasis or no. So for me, a CT scan would be selective, but then perhaps more and more use of an intraoperative ultrasound seems to be also the way to go in future, and certainly very useful for rectus diastasis.
Okay, thank you. Any other opinions, sir? President, sir, you can join with us, sir.
No, I've been listening. It's very interesting.
Thank you.
Everything being said, so nothing for me to comment. Yes.
Reliability and share wave of elastography, diagnosis of the abdominal hernia disease should be further evaluated. The grade A, like high frequency ultrasound recommended to deficit and diagnosis of the rectus disaster. Like this is the guidelines from the IEHS. Next question for Dr. Filona. There's a role of mechanical bowel preparation prior to the LBHR. Do you use it on regular basis, or in ideal you have any ideal preparation of choice or any other specific contraindication for the preparation?
I only use it for if I'm doing complex ventral hernias. For simple hernias, I don't necessarily do mechanical bowel preparation. Of course, it also depends as to the type of surgery that was done before. If you feel that there might be some bowel distension during the surgery, then certainly you may use bowel preparation. But I normally reserve bowel preps for more complex surgery, but not the usual run-of-the-mill incisional or ventral hernias. Contraindication, you have to be careful with patients with renal conditions because some may have renal effects for these different types of mechanical bowel preparations.
Any other opinions, sir? If there is no other opinion, like I think so, we can move with you. But like I say, just say the mechanical bowel preparation for the prior to LVHR may be the useful in selected cases, but additional evidence on its risk benefit is needed before recommendation can be provided. Okay. Now, the Dr. Flavio. It's a simple question, but like, what is the ideal patient position for performing the laparoscopic ventral hernia repair?
I think it depends on the repair that has been done. So the traditional lateral approach works well for the midline hernias. I like to put the table a little bit higher so we don't strengthen down with our shoulders. I like to do modified lithotomy for scola because I'm looking up. But the lateral approach, the lateral position is only for those lumbar hernias. Otherwise, most of my laparoscopic repairs used to be just lateral approach. And a key aspect is sometimes I miss in Brazil, I don't have that issue here, is a 5mm scope, because that gives you a lot of freedom to move around and make yourself more comfortable. When you have only a 10mm scope, you're kind of locked with that scope in one port. So you are playing around with your shoulders. But if you have a 5mm scope, it's very interesting to help you with the position.
Any other opinion? Dr. Avinash, you want to add on something?
Well, my preference for almost all the hernia repairs that I do would be a supine position. I would restrict the lateral position for lumbar hernias, like Flavio mentioned. Prone is almost never done by me. And yes, for when you're looking up towards the xephisternum, you would like to have a modified lithotomy where you're with the legs apart and low enough not to come in your way. But by and large, my default setting would be a supine position.
Okay. How do you plan?
Can I just ask a question here, Siva?
Yes, sir. Please, sir.
Yeah, in fact, my question is to Rahul and those people who do quite a lot of the E-TEPs. Now, what I believe is the best position for an E-TEP is that sort of a position where you have, the tummy of the patient the sort of highest, where there is a break in the in your table at the level of the umbilicus or so that becomes more prominent. Now, we had a problem in a patient who had, limb weakness, lower limb weakness following that repair. And what I want to ask is there, something similar seen by the other surgeons with that sort of a slightly jackknife position, if you can call it, with the tummy higher and the head and the feet lower. So what I'm asking is that a problem? Is that a problem with leg weakness or tingling or numbness in the lower limb? Following that position.
I use we call here a flex position. I put the flex of the table at the hip level of the patient, so it breaks down. That increase the distance between the anterior superior iliac spine and the rib cage. So that distance can be small, and when you open the patient, flex the patient, that distance becomes wider. This is very important for robotic repair because you have less collision. And this is a very interesting point that you raise. I have one patient that comes with a leg pain, and the patient has prior spine problems. So now I really look after those patients with prior back problems, spine surgery, and I'm more conservative with this flex. But otherwise, for a healthy patient, I really do a real flex position to help me with this E-TEPs robotically.
So only thing, like, we come to understand, like, the proper history is important when we are going for a E-TEP in such a position, because, like, if the patient have the back pain or previous surgery, the patient can collapse, they can go for the numbness or like weakness of the limb post-operative.
Can I share the screen just for the showing this position?
Please, sir.
Just 1 minute.
Yeah.
Now, if you can see here, this is the position. That is what. Oh, sorry. This is the. This is
share your screen, Rahul.
Yeah. 1 minute. This is the position what Sharma sir is talking about, right? This is the breaking of this table, and what Flavio said is right. You have to see that your hip, the patient's hip should be at this level, and the rest of the abdomen is above this, and then you should do a leg split position like this. Okay, but thing is, as Flavio has rightly mentioned, you have to see you have to ask the history for the patient and whether he has undergone the spine surgeries or not, because that creates a problem for giving these positions. I have operated 2-3 patients with spine surgery, but in those cases, I have not done this flex position. I have done it in a completely supine position. So, because that is not recommended, because I asked the operating spine surgeon that time whether I can go ahead with this particular position. He said it is not possible. If you do this, then the implant which they have put inside, that will break completely. So it is not recommended. So we have done that procedure in supine position. It becomes little difficult for us, but yes, you can do that.
Okay, thank you very much. And like, how do you plan your OT layout on the port placement for this type of hernia? When, like, there is a epigastric hernia, it's umbilical hernia, or like when there is a there is a intra-umbilical hernia, how you are going to place your position? Dr. Alex Naveen?
Yes, sir. So it depends on the site of the hernia, naturally.
Yeah, exactly. That's
and
what the people want now, like juniors.
So basically, if we are looking at something which is centrally placed, then there are many options. One, you can go with the standard lateral approach if you're going for an IPOM, or you can go like how some surgeons prefer to go from either the epigastric region to approach it. But the other ones, which are more upper or below placed or more laterally placed, then naturally we tend to stay away, stay at the region of the abdomen, which is furthermost, so that you have enough place to play around with, and most importantly, you still have the triangulation benefits. So that is something that we should definitely have an idea on. So infraumbilical hernia, as you have placed here, sir, I would probably go with what you have put the ports there in the epigastric region and aim towards the bottom. That's all.
Any other added on opinions, sir? Like mainly,
Shiva, it is like this. You know, you must, I think, consider the hernia to be the center of a circle, and then you have your 3 or 4 ports placed in the form of an arc of a circle.
exactly.
So the center of the hernial defect becomes the center of the circle, and your ports need to be positioned in the form of an arc. By and large, that holds good for all hernia positions.
Thank you, sir. Thank you. Like the next question is like the protocol for the urinary bladder catheterization during the ventral hernia repair, laparoscopic ventral hernia repair. Dr. Rahul, sir.
In my own practice, I do catheterize the patient for any ventral hernia repairs. I always catheterize the patient. If everything goes smoothly, then within 24 hours, next day morning, I remove the catheter. That is what is my protocol is. And I haven't found any difficulty for doing this.
Any other opinions, sir?
Yeah, Shiva. Avinash here. Yeah, as a rule, I don't try and catheterize all my patients because obviously it is a focus for a UTI and an infection which can then involve the mesh as well. When I'm anticipating a very long surgery, when we are operating infraumbilically and in the pelvis, those are the few exceptions where we would want to actually have the catheter in place so that the bladder is nicely decompressed and the anatomy clear.
Any other opinion from the panelists?
Yes, sir. If in an IPOM and if you're dealing with a suprapubic hernia or a lower one for that matter, definitely there is an indication for catheterization. Whatever said and done, as you've put beautifully in this slide, it might even help us with defining where the bladder is to maybe dissect preperitoneally in front of it. Or even if there is a chance of an injury, it's definitely easier to identify when the patient is already catheterized.
So what the sages is saying, like you depend on the anticipation of the duration of the procedure one and the location of the hernia. Then like near the symphysis pubis, like whatever you people told, like it's must like because like there's a chance of bladder injury when there is adhesion. So I think so like we can jump over to the next question as the time limit is like less. In adversarial lysis during the laparoscopic ventral hernia. Doctor. Halona.
Yes, Shiva.
Yes, sir.
What was the question? This one, the principle?
Yeah.
Oh, of course, try to use cold scissors as much as possible. If the intestine is quite stuck, then I normally cut the peritoneum. So better leave the peritoneum in the bowel rather than the bowel in the peritoneum. I normally will not use thermal devices or advanced devices like harmonics, and unless I'm pretty sure that what I'm cutting is just the omentum or fat. And I try to shift the camera every now and then to see the different views that I can see, because sometimes you are cutting omentum but there's a bowel at the back and you won't be able to see it. So just follow the same principles in just like in open surgery. You use cold scissors to cut everything.
Exactly. Any other, sir? Any other opinion? Here, don't tell like Dr. Shiva, like I am an initial surgeon. I want to do a harmonic scalpel or a vessel sealing system here. Okay, just use whatever like doctor told, like that. Just use a scissor without any cauterization. That's all.
And you have to make sure that you use the proper instruments in grasping your bowels, because you have to you don't want to make a lot of serosal tears if you are too rough in handling of the bowels as well.
Any other opinions, sir?
Yes, cold, sharp, and blunt dissection is ideal. But if at all you do have to use an energy source, try and avoid using monopolar diathermy. Try using a bipolar or an ultrasonic shears. It will be more useful in the vicinity of bowel.
What are the SIGs told? Everybody told that. Like, so I don't think I should repeat that again. What is the best technique to measure the size of the defect? How do you finalize the ideal size of the mesh to be used? I think so. Like Dr. Avinash, you have to answer this.
Yes, the best way to measure the size would be what you see intraoperatively with the scale, and even your pre-op CT scan gives you a very decent accuracy as to the size of the hernia. Many of us, with time we get a little lazy and we just try and eyeball it and give a rough size of the hernia. Sometimes you try and measure it externally. When you do that, you need to make sure you're taking into account the patient may be obese and the outer and the inner circumference may be very different, and these shortcuts may land us with the wrong size of mesh. Now there is a new concept where instead of just giving overlap in terms of 5 or 6 or X centimeters, they're actually looking at the surface area of the defect versus the surface area of the mesh. I think Mackie mentioned the 16:1 ratio rule, and that's what is used now.
Dr. Flavio, I saw you like when you're doing the term, like you are using a scale inside, like the internal measuration. Any other opinion from you, sir?
Yes, I routinely use an intracorporeal ruler to make the measurement from the intracorporeal aspect. I really don't trust the extracorporeal measurement. As was said, the obesity is a big issue. Right now in my practice, the mean BMI of the Bronx person is 37. So the mean BMI of a person that lives in my area is 37. So obesity is a real big problem in my practice. So I need to rely on the intracorporeal measurement. I always use a ruler. I completely agree with the idea of the ratio of the mesh area and the defect is better than just a plain 5 centimeters overlap. I use a 5 as my minimum overlap, and I try to always to use a big mesh. 16:1 is very, really high, and it's hard to measure the defect area because the defect is not a simple geometric form. It's not a square or ellipse or a circle. So it's kind of difficult, but anyway, I like the ratio idea.
I think two things we have to remember here is one is overestimating. If you are overestimating the defect size, like you are going to get a larger mesh inside and you are going to struggle. And if you are going to underestimate the defect size, like you are going to the processes size is going to small, the recurrent size is so the measuring the defect, whatever the way you measure, the external way or internal way, the measurement should be correct. That's why we are like saying, like Dr. Flavio was saying, like the CT scan, like or the ultrasound before the surgery to know about the defect size and multiple defect, like it will be helpful. Even the Surgical Society of SAGs is saying that same thing. Now,
if I may add one more thing, Shiva, sorry. It is important to reduce the pressure of the pneumoperitoneum before actually measuring your size, because a tense abdomen may give you a wrong reading.
Okay.
Shiva, may I comment? Shiva?
Please, sir. Please, sir.
Yeah. One thing that we also do in our hospital is that even before distending the abdomen or even before the induction, we sometimes use the ultrasound to mark the defect size. And you may have an idea already as to how big the defect is pre-laparoscopic or pre-insufflation. So that could also help you in measuring the defect, aside from doing the measurements as well during your procedure.
Okay, thank you.
Just a question, Shiva.
Yes,
So
sir.
if you can get the defect size by ultrasound or by CT, is it necessary to measure the defect operatively?
Exactly. So we have to measure, because even though the ultrasound or CT can like what it's my opinion, what I'm coming to say is like the intraoperatively measurement is much important, because even the primary hernia will be there. Sometimes the small secondary hernias will be there. We should not mess when we are displacing the peritoneum or falciform ligament. We will come across the small hernias. Even the size of the hernias, like intraperitoneally, it will be differ. It's like externally, it will differ. So all the combined together, it will be useful, which is my opinion.
What do the other panelists say?
Yeah, old jungle saying, seeing is believing.
I totally agree.
What is the president is saying, sir? What is the president's opinion here?
No, I think you should measure it intraperitoneally, as Avinash said, by reducing the intraperitoneal pressure. And I think that's the way forward. And also, as you know, it is not always a square or a circle. You have to measure in two places, longitudinally and transversely, and get an idea. That's what I personally feel.
Yeah, I feel in a primary hernia, I don't really measure because I know the measurement from ultrasound. But in all secondary hernias, I certainly do that, because after you release all the adhesions, the fibrosis and all that, definitely there is going to be a small change in the measurements. It's not going to be the same. So I think in secondary hernias, it's definitely important to measure.
Okay, I think so. Like that sort of time, we'll go to the next question. Persistent pain following the laparoscopy ventral hernia treatment. What is the treatment of choice, sir? Dr. Rahul, sir. Hello, Dr. Rahul.
Hello.
Yes, sir.
For the see, the main causes for persistent pain is either a transfacial sutures or the tags. So we need to see for whether we have used the tatters, and to reduce that, what we started using is rather than using a foreign tax, we are using all the absorbable tax. That after the at least at the end of 1 year or so, the tax will be completely absorbed. So that is how it goes. And for the transfacial sutures, you can do local injections as well, the local anesthetic also. Or you can say if the patient is having pain which is non-tolerable, then you can see for the pain management for those particular things. And very rarely remove the tack and this thing, the permanent tax is there, and that is causing the problem. And even for the suturing also, previously we used to use the proline sutures. We have shifted from proline to the absorbable sutures, like long absorbable sutures, what you can see like a Maxon or a PDS sutures, 10 PDS or 1 number PDS, that is been recommended, or the transfer sutures as well, because that is going to absorb and automatically that will reduce the pain factor.
Yes, sir. Like whatever the thing is, like stages, is persistent pain following the laparoscopy ventral hernia repair should be treated with analgesic, anti-inflammatory medication, steroid, trigger point injection, nerve block. Otherwise, you have to go for your removal of your tackles or suture. What is the management of the postoperative seroma? How long do you observe when you are going to intervene, and how do you intervene? Dr. Naveen Alexander, sir.
In my experience, sir, I have only observed. I have never intervened at all. And experience-wise, it has all settled down, God forgiving us. So I've never intervened. That's how I have done it, sir.
This is an important question for the beginners. Like that's why like I'm asking like a different opinion from each and everyone. Please guide us like for the juniors. Any other comments, sir?
If I may continue, sir, I think, reading from the guidelines earlier, there is a very, very low evidence to say that in case it doesn't settle down, there is a role for aseptic aspiration. But I'm not so courageous to do something like that. Definitely with the advent of IPOM Plus for the last 2-3 years that I have been doing IPOM Plus, I have found that my seromas, in fact, settle down faster than before, which was just a bridging repair.
Yeah, so I tend to agree with that. I just sit tight on them. I wait as much as possible. I will never do anything before 2 to 3 months of observation, unless they become infected as what is extremely rare, or they are very, very, very symptomatic. Otherwise, I wait 2 or 3 months. And after that period, if the seromas are still there, but the patients are not complaining, I just leave them. I don't touch them. If after 3 months and the patient are complaining about the bulge or something, we can try to aspirate, but my experience that usually we need to go to a small incision and resection.
Excellent, Flavio. Like what is the thing is like now the 3 months, like wait for the 3 months. That is even like counseling the patient is important. Preoperatively, there is a chance of seroma formation. It will be persisting for at least 3 months. Don't go to the nearby surgeon. And like if they think like they may convince the patient like again like recurrence of hernia. So that is the counseling of the patient is much important before the surgery. In certain patients, in some patients, there's a chance of seroma formation. If there is a seroma formation, there's a recommendation which should be followed. Right, sir?
Yeah, and you bring an interesting point, because I've seen it was a patient of mine that he was an inguinal repair. The patient was fine. He got a seroma, and he went to another surgeon, and the surgeon told the patient there is a recurrence, and he operates the patient open, and he found a seroma, and he was intrigued because there's no hernia, just the seroma. And say, sure, you were not to listen to your patient. This is just a seroma. So nowadays, I explain all my patients, they are going to expect to have a seroma. Don't worry, we will deal in the future. But this instruction of the patient is a key for a good outcome.
Thank you. Thank you. If there is a mesh infection, can you still salvage the mesh? Is the mesh excision is the only option? Dr. Anil Sharma, sir?
Yeah, Shiva, it all depends, like, what the state of the infection is, what the sort of clinical presentation of the patient is. But then most of the time, if you have a patient with a mesh that is floating in pus, where you can see a lot of fluid, a lot of debris around the mesh, by and large, these meshes need to be removed. These are not meshes. So it all depends on the state of the mesh, the state of the patient, but then treat them sooner rather than later. Surgical excision sooner rather than later. You will save your patient a lot of pain and misery and suffering if you sort of go into.
I think so. You are breaking, sir.
Remove that mesh sooner rather than later.
Thank you, sir. Thank you. I think so. This is the last question. Mesh fixation above the costal model. What are the special precautions you will take? Tips and tricks. Dr. Flavio?
Go preperitoneal. This is the best thing that you can do. Just dissect the peritoneal off of the diaphragm. is thin, but you can do it, and you can go all the way up to the central tendon of the diaphragm is necessary. You're going to lay your mesh. If your mesh is still intraperitoneal part of it, that piece of the mesh goes extraperitoneal, so you don't need to fix that part. You just put a couple of sutures or glue, and you don't need to do penetrating fixation above the costal mark. I think this is the best thing that we can do.
Any opinions? So it's
yeah, so for certain no fixation,
your voice is breaking. Stop your video.
Penetrating fixation above the, fix, right at the costal margin, but then beyond that, on the chest wall, one should not use a penetrating fixation at all. What I have seen some surgeons do is to pinch up the peritoneum and then take a suture and fix one part of the mesh, with a few sutures like that. But I tend to agree, a mesh in that sort of a situation doesn't need to be fixed at all. You can fix it close to the costal margin, close to the ribs. But a mesh, lying on the chest wall on the ribs doesn't need much fixation at all.
Okay, so thank you. Next is the incidental umbilical hernia. Diagnosed on like any other cases, like you are going for your cholecystectomy, or if you are going for your hysterectomy, you are finding a small hernia. What is the line of management there? Dr. Avinash?
Yeah, Shiva, now the problem is trying to do something that you have not consented to do. So you need to be aware of that fact that if you're going to do something which is not life-saving without a consent, you could be medico-legally liable for that in the future. Ideally, if you're putting one of your ports through the umbilicus, yes, then you're fully justified in trying to close that. And depending on the nature of the procedure that you've done, whether it is a clean procedure or a contaminated procedure, you may or may not use a mesh for it.
Thank you. Any other opinions, sir?
Yeah, I agree with that. If you find a hernia that was not discussed with the patient, it's probably the patient is asymptomatic. Because if the patient complains about the umbilical pain, you're going to see the hernia. So my advice is don't touch it. If you put a cord, just close primarily, discuss with the patient. The patient has a high rate of recurrence. In the future, you deal with that. If patient, they don't care if they have a hernia or not. They care if it hurts or bother or not. We don't treat hernias, we treat patients. So if they are not consent, they are not complainful, don't touch it.
Thank you. This is the last question. Can we combine the abdominal surgery, any other like cholecystectomy or hysterectomy, with hernia? Dr. Flavio?
Yes, we can. I don't think we should. I don't see a problem to do a cholecystectomy or even elective appendectomy for any other reason. But if there is a contamination in the field, if you can try to do it in separate stages. I was much more brave in the past with that. I'm getting old. I have gray beard. I'm trying to decrease my problem rate. So if I can separate the procedures better, if not, that's okay. We all know that it's fine to put in clean contaminated cases. I will avoid IPOM meshes on those cases. IPOM mesh, they don't behave as good as an uncoated mesh. But my answer is, if I can avoid both procedures together, I would. But that's okay to do it together, probably.
Any other opinions, sir? Any other comments?
Yes, sir. So I personally feel like this scenario as well as the previous scenario is pretty much the same, because it depends also on the size of the defect, as Dr. Avinash already mentioned. If it is a small one and you're going through the umbilicus, then it's perfectly fine to repair it. Now, in a case where you think you can get away with doing an IPOM, and you've started with it, and unfortunately there's a bit of hematoma in the hysterectomy, or if you've had some bile spillage during a chole, then at that point I think we should not be taking the risk. At that point, I think just a primary closure of the defect, maybe do an onlay repair for the time being, and just wait and watch is what I would suggest.
Thank you, Naveen. Thank you. Like, I think so. Our time is like overwhelmed. We'll just start with this. And like, this is a small video for the youngsters who want to become a laparoscopic surgeon or laparoscopic hernia surgeon. I think so. Like, this will be like give some boost. Like, this is from a small movie, like a very famous movie from Kerala. This is a master who is trying to teach how to put a quota, like Dr. Flavio, like Dr. Payona. This is our favorite food in South India, like in Kerala and Kanyakumari and South India. Moreover, in India, the parotta is very famous. Like whenever we walk around the town, we also think like how to prepare the. Even we can try how to put a parotta, but like we cannot do this. Like so, this guy is trying, going on, trying. This guy is watching. It's not feasible. Everybody started sleeping, but he didn't stop there. All over night, he's trying, going on, trying. Even the moon started coming down. The sun started coming up. Even his shoulder started paining. The cats are smiling there, watching him. But he didn't give up. At last, in the morning, we found the way how to do the parotta. The Star Wars, like the HSI, is so happy to teach the youngsters. And one thing is important here: the hard work and not giving away your to cope up with the world, and you can achieve anything. You have a tired heart and eyes, you can achieve anything. This is my last slide. With this, I think so. I thank you each and everyone. Any few words before I'm giving words of thanks? I think so. Like Dr. President can give some of.
Yes. Thank you very much, Shiva. Can you hear me? Can everybody hear me?
Please, sir. Please, sir.
Can you hear me? Am I audible?
Yes, sir. You're audible.
Yes. So congratulations, Shiva, first of all, for conceptualizing this program. Your topics have been very nice. You've broken up the topics so well. And the best part of your panel discussion was that you have treated very small things which people think small, but which are so important. You know, like catheterization, using a bowel preparation. People are scared to ask these questions. But, you know, you put it there because when a youngster is trying to start hernia surgery, he feels scared to ask these questions in front of panelists because he feels that it might be a very stupid question to ask, but these are the problems he faces. So that was the beauty of your panel discussion. So I really enjoyed myself. And, you know, we are almost going to cross more than 2.5 hours, 2 hours, 45 minutes. And we never felt, I have not got off for a second from my seat. I would take this opportunity to thank all our international guests, Dr. Jose and Dr. Flavio, and all our other panelists, Dr. Anil Sharma, Dr. M. Ramesh, Dr. Alexander, Dr. Vinash, and also Ashwin Thangavelu, who's always worked behind the scenes.
Behind the screen.
Behind the scenes. He's been a very good source of inspiration. So this has been a wonderful experience. I would like to thank delegates who every Saturday, we've been having this program every Saturday. They are coming in huge numbers on this program. As I said, last time we had 2,800 people on the program. I am very grateful again to Kritika and the Docplexus team for all their support and for organizing this program flawlessly. And with these few words, I would thank all of you all to be a part of this very, very interesting international update. Thank you very much, Shiva. You always rock and you always do it so well. Over to you again, Shiva.
Yes, sir. Once again, it's very good evening to all. I would like to extend very hearty vote of thanks to one and all for sharing your knowledge with us. First of all, I would like to thank the HSI President, Dr. Ramesh Agarwalla, for giving me the opportunity to conduct this webinar. I would also like to thank the HSI office bearer for this valuable support. I consider this as a great privilege to express the vote of thanks to the stars of the day, Dr. Jose Macario Pelona and Flavio Melcher. I like only one, at least I think so, like at least 10 days back only I contacted them. It is a short time of period, like they accepted my invitation and they came to the webinar, like even like 3 hours back, like Flavio was asking me, like I didn't receive, like I think so, like in early morning at 5 o'clock or 4 o'clock, he got away from the bed and asking me like, where is the link? I didn't get a link still now. So this is the like energy which is given by all the staff speakers and the, thank you very much, sir. And Dr. Rahul Mawadar. Thank you so much. I also express my special thanks to Dr. Naveen Alexander, Anil Sharma, and M. Ramesh and Dr. Avinash Katra for adding icing to the cake. Once again, I thank you all for making this event successful, and as well as Dr. Aswin, who is behind the screen and daily contacting me us each and every time for the program. Thank you very much, Kana. And last but the least, Docplexus. It's a successful story behind thing is like giving the each and every time the links and like please like within a time period you have to stop, but like I didn't get any sound from Kritika, Dr. Kritika. Still now, please stop, your time is over. Thank you very much for Docplexus and have a nice day.
I just want to add, I forgot to add the name of Dr. Rahul. Rahul has been a very big source of inspiration. He's a very, very pioneer surgeon, hernia surgeon. Rahul, thank you very much for being on this.
Thank you, sir. Thank you. Thank you. Thanks a lot.
Thank you.
I didn't leave log groups, sir. I added on my talk.
Thank you.
Okay.
Okay.
Thank you. Bye-bye.
Thank you
Bye.
very much.
Thank you.